Okay, Pablo, I'm here.
A simple thing that's wrong with your car. So I was like, oh God.
Imad, good afternoon. I think you're muted at the moment.
Yeah. Hi, Sanjeev. How are you? Good to see you.
I'm very well. Nice to see you.
Thanks to have you with us here today and organizing the stuff for us.
No, my pleasure. My pleasure. No problem.
Good afternoon.
Hello. Who is with us?
That's Ahmed.
Ahmed Ammar. Hello, Dr. Ahmed.
أهلين. ألف مبروك.
Thank you.
الله يجزاك الخير.
Good to see you. Yeah. Dr. Ahmed Ammar, he is a senior consultant and professor at the University of the Eastern Province. Is it, what's the name of the university, Dr.
Imam Faisal ibn Abdul Rahman now. It was King Faisal University before.
That's what I remember the name.
Yeah. This is still our favorite name, but the name changed.
Sure, for sure. Good to have you with us. Did you manage with the Gail? Sanjeev?
No, so she's only sent a PDF. So I've looked very carefully through it. So I emailed again, but I think she's busy, unfortunately.
Oh, okay. Unfortunately, these last minute changes, it's make it difficult for us.
Yeah.
And we have 42 speakers over the next 3 days. All right.
So
the presentation is a PowerPoint presentation, isn't it?
It is, yeah, PDF,
But no commentary.
No audio,
so
no.
We cannot present it, She needs to be recorded,
Okay.
Very good. So how's the weather in your area in England?
Not good, cold.
Cold? This is the best time to visit Saudi Arabia.
Exactly.
Yeah, the weather is perfect. Isn't it, Dr. Ammar?
Yeah, it is. It is still a good weather. Where are you in England?
I'm at Oxford. I'm the skull-base surgeon at Oxford.
Oh, yeah. Okay. Thank you. Well, I have been there several times, but long time ago.
Oh, excellent. Excellent.
Yeah.
Actually, my family, they live there, but not in Oxford. They live near Manchester.
Oh, very nice. Very nice. And we have Professor Asra as well as joined us.
Yeah, Professor Asra. Hello, you must unmute yourself, Professor Asra. And Victor, Professor Victor Hugo with us from Mexico.
Hello, how are you?
Hi,
hello.
Great.
Hello, Professor Imad. How are you?
Good to see you. I'm fine, thank you. Hi, Professor Asra. Good to have you with us.
Yes, thank you very much.
Late in the evening now in Indonesia.
7 o'clock. 7 o'clock in the evening. Thank you for the invitation.
Yeah, it's a pleasure.
I'm glad to join. Yes.
Okay. So, Dr. Asra, I'm sure you have some bills to stay awake until we have your presentation.
It's okay. It's okay for me. No problem.
Yeah.
Again, thank you. Yes.
Somebody was criticizing the issue or comment about Greenwich Mean Time. Why Greenwich Mean Time? Well, I cannot fix it to one area's time because it will affect the other areas. I felt GMT people, they have to do their own calculation. I'm expecting neurosurgeon should be able with their smart navigation with time.
Of course, no problem. No problem at all.
Yeah, that's true. Stefan, I think joining us, Stefan Florian from Romania. You have to unmute yourself to hear you if you want to greet the colleagues. Stefan? So, Victor, how are you? Long time no see.
Fine. Last Congress was very nice, very beautiful. We had almost 250 people there.
Wonderful.
So COVID is going down. So we had a good time. We hope to celebrate another Congress on May. All of you are invited. in the fourth week of May next year.
And it will be in Acapulco as well?
Acapulco again, and in November next year in the southeast in Mexico, probably in Chiapas or Villahermosa, Tabasco. These are really beautiful places. So hope you could come. I think it could be a little bit difficult because of the Congress in Brazil and Colombia, Bogota, but probably next November.
I will book my tickets already from today, and I'll take with me Professor Suresh Nair, who is on the screen now. Unmute yourself, Suresh.
Good afternoon, Imad, and good afternoon, Victor, Ahmad, and all of you. And
good afternoon,
Imad, you have done in the last couple of years, bringing all of us together multiple times in this wonderful WFNS anatomy webinars. Hats off to you, Imad. And you are such a scholar, teacher. I don't know how to describe you. And I hope you will continue to do this in years to come, Imad. Great.
Thank you. With your support, we hope the best, actually. Florian, are you on? Stefan? I'm seeing Igor, or who is there as well? Yeah, Igor.
Hello.
Good to see you. Hello.
How are you?
Igor. Is this a yellow scrub, or this is a?
Oh no, this is only for the lab.
Okay.
Yeah.
So interesting. No, this is the first time I see for the lab yellow. Okay, wonderful.
How are you?
I'm fine, thank you.
Hello, everybody. Imad, how is the policy for questions? We'll do that at the end, during the webinar?
No, you see, the question should be only on the, what you call it, on the chat. And I request all the speakers to answer this question because of the number of speakers, you see 42 speakers, it would be very tough to open a big discussion. And for the event's sake, this is an appreciation and ownership for our colleague, Professor Franco Sevade. So we won't have the chance for a lot of discussion and as usual. So I will trim it only for the presentation and we just move. If somebody finish earlier, we might privilege that to take one comment or question if he finished early. But I doubt everyone wants to finish the last 15 minutes. That's what's happened. Okay. Stefan, good to see you.
Thank you for the invitation. Nice to see you.
Hello, Stefan. Haven't seen you for a long time.
Hi.
I'm seeing Ramesh. Ramesh is with us.
Hi.
Good to see you.
Hi.
And Franco, you just joined with the pullover on. Milano must be very warm, like Riyadh.
It's cold.
Hello, Franco.
Hello to everyone.
Hello.
Wonderful to have you also.
Ramesh.
Buongiorno.
Thank you.
Hi, Professor.
You look great, Franco.
So, Franco, I have to tell you, it was not an easy task. I thought there would be a limited number, but everyone wants to be part of this celebration. I don't feel it's a celebration because we are going to miss you as a president, but you have paid your dues. I am sure you are ready for it to have a different path and lifestyle.
I'm very grateful to you for organizing such a meeting, and obviously it's not part of my view to be so exposed, but I am grateful to you. You have seen that I left the World Federation with a simple letter and nothing else, because this is the mandate you have. You have to work, and then the other one will judge you, not yourself. This is, but I am really grateful to you, Vladimir, and everyone for coming.
I'm sure Vladimir will join us shortly. I think once he has a CP angle, I thought, oh, he's jumping now on CP angle tumors, but not for today. I think for tomorrow. Yeah, but he will join shortly, and I have to apologize.
Good afternoon, Professor Franco, Professor Florian. Nice to see you.
Suresh, nice to hear and see you. Nice. I'm very happy.
Hi,
Hello,
Igor.
Igor.
Nice to see you all.
Nice to meet you.
Victor, Igor, and my friend Rosamar, everybody is there.
I have to welcome Professor Takashi Kon. He has been always with us.
Good evening, everyone. So,
good to see you.
this time also, I'm very interested to join.
The transmission to the Japanese colleagues as well. And Andre with us, Professor Andre Grudenhaus from Dutch, Holland. Hi, Andre. Unmute yourself if you want to say some words. Andre, unmute.
Yes, I'm now muted. Hi, Imad, and I see Suresh, and I see Ahmed, and
hello, Andre.
And Stefan,
hello,
and Ramesh.
Andre.
Oh, there's all the friends, and Franco, of course. They, Sanjeeva also. Oh, that's good.
Good afternoon.
Yeah.
Hi,
For
Sanjeeva.
the occasion, Imad, I put the Christmas tie. This is what we call it, the Christmas tie, which is for big occasions.
Christmas time, and we have 2 more minutes, I think. We'll wait for the others to
get some
join.
coffee. Yeah.
I must say the program looks amazing. Very good program.
Thank you. Thank you. I appreciate your presence, all of you. And I appreciate the member of the committee support to this event. They have been always a prompt sponsor and always there when we need them, sometimes on a short notice. Pablo Gonzalez, who used to be with us all the time, this time he has the European course. He has to be there, and I understand him. He apologized ahead of time, but he made some preparation. I'd like to thank Professor Sanjeeva from Oxford, who kindly agreed to coordinate some of these activities for us. So they are the essential members of the committee. So as I said, there is no major questions or mini comments if the presenter finish before the 15 minutes assigned to him, due to the large number of the speaker. And I hope everyone appreciate this one. Nobody will be offended if we say no question. Professor Moody is with us. Moody Kurashi from Kenya. Hi, Moody.
Hi, Imad. How are you?
Good to have you. We have your picture only.
I'm just turning on my video, but it's not turning on. So maybe there's something from the settings.
Yeah.
I can't switch on the video. Okay.
Okay, no problem. Now, without further ado, I think it's time now is 12 GMT, and we are going to proceed. This special event was triggered by the members of the Neuroanatomy Committee of the World Federation of Neurosurgeons, and to honor our distinguished colleague, Professor Franco Sevade. As he stated correctly, and a good description, he is the humble person who acts by function rather than by speeches and talks. And my first encounter with him when I conducted the Asian Congress in Dubai, all of a sudden I saw him physically present to support the course we did for the World Federation. Amazing person, and I always say he is more on flight, going to support the different events around the world without discrimination. He knows no boundaries and no politics, which was a wonderful experience for me and for all of you, I'm sure, to have him with us for the past term he has served as a president of the society. So I would like to say that Professor Vladimir Benish is co-chair of this committee, supposed to join me shortly, and I think he is busy. And I'd like to thank everybody who attended and who submitted their presentation. There are few who excuse themselves for their busy schedule or unpredicted schedule. So we'll proceed as it goes. This session is supposed to be chaired with me and Professor Santarius from England, I'm not seeing him, but we will proceed, and I leave the venue for Franco.
Thank you to everyone. I can share my screen, Imad.
Yes.
You have to enable my screen to be shared.
Professor Sanjeeva will preparing this.
I will have a look.
I might ask all the presenters to put their speaker on mute.
So Professor Savada, you should be able to share your screen. There's a green button at the bottom.
No, now it's written, you have disabled the sharing of the screen. It's written like this here.
Okay, I'll tell you what, I will just make you co-host then. That should help you. Can you share now?
Yes, now it's working.
Perfect, thank you.
You're welcome. Thank you. So thank you all friends for the invitation. This is my big thanks to Imad and Vladimir for organizing this event to honor my presidency. I'm deeply hit in my heart. It was a fantastic experience as president of the World Federation, and it was a big honor to work with you all. My topic is about education. We do know that we have around 50,000 neurosurgeons in the world, but we have huge disparities in the distribution. You see it here, there are countries with very limited numbers, basically Africa and Southeast Asia, and we have countries where probably we have more than we need. So there are big disparities in the world. We know, all of us, that there are disparities. We will see it later in instrument. Having all instrument means green color. You see that only in US, basically, there is only the green color. Even in Europe, there are some yellow colors. And basically in low middle income countries is red colors, meaning we don't have this available. And you see that these are two of my colleagues operating in Africa by using a telephone as a microscope. And as you see, the same colleagues published a paper on exoscope. So the same people working in Europe or working in Africa, they have to use different instruments. Then there is what I think is extremely important, big disparity in publication. This is the first paper we published, where we see that only 5% of publication in neurosurgery are coming from middle and low income countries. And out of these 5%, almost everything is done by India and Egypt. So they are very limited, whereas the country most publishing are either in US or China or Japan or Europe, basically. So these are the country with most contribution to the papers. And this is the distribution of the papers published in one section. This is trauma, but it's the same all over the world. You see that the publication come from Europe, US, Japan, some in China, some very few in India, whereas the disease, this is also trauma, but is the same, are in other part of the world. So the publication is in one part of the world, the disease is in another part of the world. And this is another paper that we published recently comparing the incidence of the disease, of the neurosurgical disease and the publication. This is US and Canada. You see a lot of publication, but much few cases to be dealt in neurosurgery, the same in Europe, the other way around in Africa and Southeast Asia. So what does it mean? That if we publish and we do randomized clinical studies only in one part of the world. This is the paper that we did together with the group in Harvard and the group in Cambridge, where only 8% of the randomized clinical studies are done in low middle income countries. All the others, 92%, are done in high income countries. So the guidelines which are coming from evidence-based medicine are influenced by this publication rate, as you see it here. So we have written recently an editorial saying that we should move from evidence-based to mechanism like consensus statement, as you see it here, consensus conference, where you can invite people from India, Indonesia, Pakistan, Ethiopia, Vietnam, Tanzania. You can work much better than in an evidence-based guideline. Then, as Imad already said, I was traveling a lot. In 3 years, I visited 46 countries. 19 of them were never visited by a WFNS president. And this is a meeting in Marrakesh from all the Africans who were trained in Morocco on behalf of the World Federation. This is the paper that we published. And you see it here, they were coming from Burkina Faso, Congo, Mali, Mauritania, all sub-Saharan Africa, you see. And we have worked with them. I was present to 2 big training courses, and we asked them, what do you do in your own countries? In sub-Saharan Africa, you see that most of them were doing quite a lot of mix of elective and emergency surgery. Most of them were doing a mix of spine and cranial cases, but also many of them mostly spine. And the caseload for 12-month period per surgeon was really, let's say, enough limited, 1 to 50 here, and 51 to 100 here, and over 100 there. So how can we help our colleagues who are in these areas? Without data, we cannot intervene. This is the Global Neurotrauma Outcome Study ruled by the University of Cambridge, by the World Federation. And you see it here. We have, these are low-income countries. These are high-income countries. And the time from injury to surgery is increasing significantly from our countries to, let's say, African countries. And the same is true with many other injury to admission and so on. So we know that there are also organizational problems. Another way to help them is what we call it a twin university system. One Western university plus a university or an academic or non-academic structure in Asia or Africa. You see it here. This is one of our residents who spent about 4 months in Indonesia working with our colleagues and publishing with them. So we can do the other way around, sending their residents to collect data and to publish. What did we do as a classic education in neurosurgery? Before the pandemic, we have the frontal lessons during congress, meeting, or courses with some hands-on in cadaver approach, or fixed, meaning not you can move them, simulation centers. The WFNS has many programs. You see, there are full training program and shorter program for observation. In Africa, we have many projects for training. You see that these are the centers we have in Africa, we have in Morocco, we have in Algeria, we have in Zimbabwe, we have in Kenya, we have them in Senegal, We have many others, many centers, and with these centers working and with the work of other African new university, we have increased 5 times in 18 years the number of neurosurgeons in sub-Saharan Africa. And the other way to do was the course, in-present course, which you see, this is Cairo course in March 2018. This is Mombasa, Kenya course in December 2017. And you see these are the hands-on course with the use of computer or with the instruments you have to use. Or also big fantasy using cinema lectures, where we do, like in Indonesia, where they rented an old cinema to have a 3D surgical lectures from Professor Spethler. But after the pandemic, we have used the system which were already there. This is a paper that we have written in 2018, before the pandemic. And this is a paper about neurosurgical teaching in low middle income countries. And this is a paper published before the pandemic. There are many educational channels via web in the internet. This is an example of a webinar in March 2018 with more than 1,300 contacts on YouTube. And these were done before the pandemic. After the pandemic, you see there is a flowering of so many courses organized by the World Federation. During my period, we have counted over 270 of these courses organized by the various committees of the World Federation. And you see that the WFNS committee is up to 14 webinars. The series from Nasser El Gandour and our colleagues from Egypt only on low, middle, high income countries is number 52. The International Pakistan webinar is number 51. So there was a tremendous effort by many committees and society to organize the education during the period. What did we miss? We missed the cadaver section. You see it here, which was not possible. We do have a possibility of simulation, but most of the simulators are fixed like this. This is the largest simulation center in Europe, which is in Milano at the best institute nearby where I am now. And they have all the simulators, but it's fixed. You have to go there. You cannot see it. But we have also a project with the European community ruled by the upsurgeon, who is an Italian young neurosurgeon ruled with many people from all over Europe, who is working on a hybrid form of simulation, some via computer and via telephone, and some on site without cadavers with the simulators. Which is the weakness of internet learning? There is no quality control. Surgical approach can be posted, you see in YouTube, even if it requires a long training curve. We don't have a place where to approve guidelines, procedure, films, everything can be posted. The web is free. But as we say in Latin, ex malo bonum, we found also in the form of internet-based education, positive approaches. These are the message I got in a recent webinar. Uganda, Libya, Yemen, Congo, Mongolia, again Congo. So these neurosurgeons were never been able to come to courses or meeting on a regular basis, but they are able to come and see the webinars. And this is what is just going to finish. This is what they ask. the young neurosurgeons from low and middle income countries were investigated about what do you want the WFNS to do after the COVID. And you see that they wish to have an online curriculum, they wish to have virtual laboratory, they wish to do research with high-income country universities. And this is, as an example, a surgical survey from the Young Neurosurgical Forum and the World Federation about the capacity of doing clinical research in your own university. So in conclusion, we need the target educational activity. Web-based education is important, but cannot be a substitute for hands-on education. Hybrid system, when we combine web-based education, virtual reality, hands-on activity, are probably the best for future solution. This is wrong. You know, this is what is in the, it's wrong, sorry. Mi può richiamare 5 minuti. It's wrong. You see, this is a neurosurgical cocktail, 24,000 accessed by neurosurgeons. And you see that the question is, who is a great neurosurgeon? If you publish book, if you do many surgery, if you teach and speak in conferences. Obviously, they had an overwhelming of responses being 2, who does many surgery. But we think that the neurosurgeon is able to do both, to write books, articles, and to work, as we have done for all our life. And the last slides, just to thank again Imad and Kanam, and to thank today all the people who send me messages after I finish my mandate, and you see it here. There is only a few word messages sent by me by the Young Neurosurgical Forum. We thank you because you did what you promised, and this is the best compliment and the best compliment I never had. So thank you for your attention. Thank you, Imad and Vladimir again for giving me this opportunity.
Well, thank you very much, Franco, for this excellent presentation. It's again confirm and speak for itself. Figures and function speak for itself, for the leadership you have conducted during your term, and having this objective analysis of the visits. Is not only in passage visit to these countries, but you analyze figures and you gave us great messages that we all appreciated. I think I'm sure there are many that would like to commend you on this presentation and on your work, but it will go as we go with the presentation. So I'd like to invite Professor Ahmed Ammar, who is a close friend to Franco. I know that for many years. He's a friend of mine, and he is a professor in the Imam University. They changed their name at the Eastern Province, Saudi Arabia. Professor Ammar, he was going to talk about ethics in everyday practice, an important subject to be tackled even for education.
Thank you very much, Dr. Ahmed, for this kind invitation. Such meeting I cannot miss, because as you said, Franco is, we have been friends, close friends, for nearly 40 years, since we started neurosurgery together in Sweden. So Franco Servade is a very special person. He is really a man of his word. And as he said, or somebody said, and I said always, what he says, what does he mean? And he does what he promised to do always. So can I have the share screen? Yeah.
Yeah, we should be able to, I've enabled it for
okay,
all.
I did it. Okay,
great.
Thank you. So I have obviously nothing to disclose. When we used to talk about ethics before in medicine, as it is part of the graduation ceremony as Hippocratic Oath, but when we think today, do we really remember it? Do we value it? Do we go with it? Now, we used to before to talk about virtual medicine. Is it a history now and medicine is a business? If we call some of the leaders in our history of medicine, like Sir Osler, he said, as a practice of medicine is not a business and it can never be one. The education of the heart and the moral side of the man must keep pace of the education of the end. We are here to add what we can to the life, not to get. So, but this is a situation nowadays. Now the medicine has changed. We are entering a new era. That's why we started to see a lot of people coming, and several in the last 4 weeks. I can tell you, in the last 4 years, we have 4 books, new books about ethics, and we started to have a lot of theories. I'm not going to talk about this today, but I'm going to talk about it's a challenging what we have. Now we have a serious challenges for the people who are interested in ethics. We are about cross-border treatment and surgery, like telemedicine, robotic surgery, informative communications as artificial intelligence, machine learning, and computer-based augmented reality, implanted brain microchips interface, and the other technique about the validation of any methods started. Many we see every day a new technology coming up. Nobody knows it is validated or not. And what about patient safety? What about patient right? What about consent? What about accountability if there is any mistake? What about the license if doctors operating across the world? And what about the equality and the equity? Are these new techniques and modern technology only for rich countries? So if we can see what is the dilemma the people who are really interested in ethics are facing nowadays. So we see like we have now artificial intelligence. We don't know what is the code ethics for it. Nanotechnology, high Tesla MRI, which is coming soon. We don't know what are the side effects. About microchips implants, about robotic surgery, telemedicine, as we said before, and also the biotechnology, brain wiring, memory booster, reconstruction of spinal cord. All this, we will come all this invention, or we will come all this technology. We need them. But the most important thing, how to regulate them and how to build an ethics. And what is coming again, what they call it smart computer or computer-based. Now we are talking about creating a robot who can, that robot, program itself. So it can go beyond the initial programmer. If that's happened, and if this robot is doing surgery, and there is a mistake, who is accountable? Is the one who made the program, or the company made the robot, or the one who used it? Who is accountable? So we have this unprecedented challenges. At the age of major changes in medical, and again, we will come very much, and we need such new inventions and new technology. But still we have problems. We don't know really, that is, how these things can be regulated. We don't know really, that is, yes, that is how patient, for example, can consent for somebody he never met for surgery or interference. We don't know, for example, how can it be any technique or any robotic surgery or any rewiring or implanted chips, who is accountable if this mistake? We can have virtual meeting. Beautiful, as Franco said, we can use it in teaching, in education. We can have even virtual hospitals. And they started to have some places here. You see, we have virtual OBDs. I had a virtual OBD during COVID. We can have virtual lab. We can have robotic surgeons. We can have robotic nurses. But we cannot have virtual patient. Patient is a patient. Real is a real person with blood, flesh, and pain, and fears and dreams. And who is the seeking help? So everything can be virtual except the patient. So modern medicine ethics should be the foundation which we stand on it. So a great development that we said we have to think about the human rights, patient rights, and doctor-patient relationship and justice and all the fundamental. We are required to, Aristotle said, we are required to treat similar cases alike. Are we are going to do that, or we are going to be very away from that? So if we go quick about human rights, the right to be treated effectively is a fundamental human right. Actually, it is in the first document of first item of the first chapter in the United Nations Human Rights. Patients should, or humans should have an access to be treated. Conflicts in major industrial countries. Of course, this developing needs a lot of money, a little support. And that is how we can get this. If you don't say about quality and equality, and that is the cost and the availability every place. Then what about the waiting list, which it is getting longer and longer by time waiting for the new technique? And what about the conflicts between developing country and very advancing countries in regarding using the same, treating certain type of diseases? And also, there's an ethical questions now came up. The patient, does he deserve to be treated as he deserves or wants, or as his doctor see he needs? It is a conflict between, not a conflict, but this is an equation between what do we need and what you deserve. And this is became also an ethical question. So there is confident relationship with patient. Virtual medicine traditionally, patient-doctor relationship, special bond, amalgam of different values, factors, trust, honesty, availability. That's what we always say. But today's medicine, the doctor is not loyal to the patient, per se. Maybe he tried to do his best to do this, but he is more loyal to the company, to the hospital, to the insurance company. And the patient comes second. This is reality, and this is increasing. So patient-doctor relationship, which should be basic ethical platform for the treatment, but which should be direct. Now it's not direct anymore. It is interrupted by many things. But which is worse? Now even the patient doesn't know who is the doctor he is going to treat, if it is going to cross countries or virtual or whatever. And also the patient or the doctor, he doesn't know actually who is the patient. So it started to be, you treat a disease, you treat a number, but you don't treat a real human being patient. And this also another ethical problem, serious ethical problem. So the ethical issues a lot. The human rights, how can be preserved? The conceptualism, that is, if are the outcome of the surgery or robotic surgery or technology can justify what we offer by that new technology, or doesn't? How do you use the law? How you use that to utilize that is values and law and needs? Equilibrium is the balance between the advantage and disadvantage. All this ethical terms, but what about privacy concern? And this is a very major issue now. I have several papers I read recently about artificial intelligence, because you cannot have any privacy if you have that is going for artificial intelligence. So this is something also has to be worried about. And about documentation, how you will document if you will be treated by telemedicine or cross-country or artificial intelligence, where will be your documentation? In the hospital where you're treated, or somewhere else? And then coming is an important question, informed consent. If someone is going to treat me from outside the country, how I can consent to him? Which kind of consent? And what about the legality of this consent? Then vulnerable group. How are you going to deal with them? So patient also has concern. So this is a previous, this is the absolute ethical question, but now the patient would like to have the best service for him. He has the right to be treated the best. He would like to be cured. He would like to be free of his medication. But how can be he sure about the diagnosis? And how can the patient be sure about this treatment or technology is really good? Is there is a good validation for it or not? And it's fair documentation, not commercial documentation, not commercial justification. The documentation, where his documents will be, and this is with his privacy, and what about his rights, and about the patient-physician relationship. And also, how can you respect, because we have to admit about cultural, religion, varieties. How can really we, accept all such kind of varieties? Doctors also, they have concern about how possible the clinical diagnosis be made for a distant patient is right or wrong. So if I was asked to use the robotic surgery or technique to operate such a patient, or to describe medication, or to do social investigation, so I got label diagnosis and go according to it. So this many people, and I was engaged in some cases, I don't know if this is really the right diagnosis or not. And how can I order investigation if I don't know what's available in that country and what's not available? And I prescribe even simple medication if it is available or not available there. So we are really coming to a big dilemma. At the age we have to, we don't say we should stop it, but we say that is we should study the problems and be one step ahead, so we'll be able to solve such kind of problems. So the challenges we have with telemedicine, as I said, and also medical license, because this is very, now I think that is a travel medicine or robotic or telemedicine and all this technology, that is you will get people from a country to operate. Saying, what about the licensure? Are they licensed or not? And who is going to protect them? Insurance company will never protect them. So if something goes wrong, who will protect them? And then for the patient, for example, if I am from country A operated and visits country C or operates through robotic or treated telemedicine, or I visited and operated there, and then I left, and the patient tried to find me, to ask me simple questions. How can they find me? This is really a fixing. Then they come to the technology. Also the industry.
Dr. Ammar, sorry to interrupt you. You have 2 more minutes, yeah?
Okay, I will come to the conclusion, because this is almost awful. The technology actually also have a lot of problems. That is, it costs money and needs money. It's take healthcare system, global medicine, challenges, global medicine. Okay, so I would like to come to conclusion. The right to receive medical care is one of the fundamental human rights. Medical ethics and values are the core or foundation of medical practice since medicine started till today and will be till tomorrow. The emergent new technology is very welcome as long as the patient's safety, benefit, and rights are observed. New research to develop further technology should be encouraged and supported as long as the ethical research and innovation are strictly followed. Values are also relative. So the values-based medicine can be a solution. So the ethical concern is, as we said, but the most important, all this robotic surgery and telemedicine, new technology need ethical code. Question, who is going to write the ethical code? The manufacturers, companies, the big countries, the poor countries, the society. I think this is a job of WHO and World Federation of Neurosurgery. This is an important task to start to study one step ahead all this emerging technology and write an ethical code for each one of them. Thank you very much.
Thank you, Dr. Ammar, for this very comprehensive review of ethics in this very important subject and tackling all the aspects of it. We pushed you a little bit with the time, sorry about this. I might invite the next speaker, Professor Nasser Al-Ghandour from Egypt. Are you there, Dr. Ghandour?
Yes, yes, Ahmed, I'm here. Would you allow me? How are you, my friend?
Yeah, good to have you, Professor Al-Ghandour from Egypt. He was the president of the society, Egyptian Society. He is the treasurer of the World Federation. He is a very active person on education and teaching with more than 52 webinars. We just witnessed it by the numbers given by Professor Sebade, and I opened the venue for you to talk about the important review of the past 2 years of the COVID events and how we manage with education and teaching. Go ahead, Professor Nasser.
Thank you very much, Professor Ahmad Kanaan, my close friend, and I'd like to thank you for this great initiative we are gathering today to honor Professor Franco Servadier. Actually, Franco Servadier, he gave Africa the maximum support. He was a great leader during a difficult time, which is the COVID-19 pandemic. On behalf of all African and Egyptian neurosurgeons, I would like to thank him for this support he offered our neurosurgeons in Africa and in Egypt. Friends and colleagues, I will talk today about the impact of COVID-19 on neurosurgical education. Introduction. The coronavirus pandemic has affected all aspects of human existence with social and psychological repercussions that generations have not witnessed before. As the virus is projected to afflict large proportions of the world population, clinical research at all levels has been suspended. Conferences have migrated from the classroom to the digital screen. As a result of this major change in the method of education and with the eruption of virtual learning, many important questions arise. Impact of COVID-19 pandemic on neurosurgical education. Can virtual learning totally replace in-person meeting? What are the limitations and the challenges of virtual learning? What's the opinion of neurosurgeons about this new platform? In order to answer the questions, we performed 2 surveys, a global survey and a continental survey. We start by the global survey, which was distributed across the globe, and it was translated into 7 languages. And we had a very good response from across the globe. The components of this survey are the first one, participation in virtual learning during COVID-19. The second component, what is the opinion about virtual learning, especially on the process of neurosurgical education, and what are the future perspectives? We use data analysis, chi-square, Fisher exact test, and multivariate logistic regression analysis. It was possible to do these statistical methods because our respondents were 891, covering 96 countries. 165 were from Africa. Countries were classified according to the World Bank classification, depending on the income, into low, lower, middle, upper middle, and high income countries. This shows the incidence of participation among the different categories. Again, we use the World Bank classification in order to classify the countries according to geographical distribution. This shows the incidence of participation among the different regions. It shows the incidence of participation according to practice settings. And as you can see that the academic practice was the highest incidence. This bar graph shows the incidence of participation according to specialty. General neurosurgeons constituted the maximum incidence, 74.3%. Incidence of participation among faculties and trainees. We start to speak about the first component, which is a comparison between the period before and after COVID-19 pandemic. As we can notice that the index of participation in virtual learning increased from 46.9 to 78.3%. Participants said that they were paying 51.3% before pandemic. After pandemic, this incidence increased to 79.8%. Incidence of participation according to organizations, and as we can see that international organization activities were constituting the highest incidence. Second component was concerning the opinion about turning neurosurgical education to be virtual. When participants were asked, could virtual learning totally replace on-site meetings, 32.9% said yes, whereas 54.7% said no. Are you interested to attend the virtual learning meetings? 74.3% said yes, whereas 22.3% said no. This shows the incidence of different subspecialties. Now we speak about the future participation in virtual learning. What's the future perspectives? You expect an increase in virtual learning in the future? 69.7% said yes. Can you pay for virtual learning in the future? Still 13.7% said no, we are not willing to pay. And whereas 64.1% said it depends on the content. What are the factors influencing participation in virtual learning? The three most common factors were the cost, which was very important, and the time flexibility, and the speaker list. Could virtual learning alter neurosurgical education in the future? 62.4% said yes, whereas 17.6% said no. We were able to do multivariate logistic regression analysis, and when Sub-Saharan Africa was compared to North Africa, Sub-Saharan Africans said that the virtual learning can alter the procedure of education in the future. And Sub-Saharan Africans says that they were willing to pay because they need to be educated, as we can see from this logistic regression analysis. We were published to, we were glad to publish our results in the Neurosurgical Focus in December 2020. Speaking about the global survey, this was run by the Young African Neurosurgeons. As Secretary of CANS, I distributed the survey into the 5 regions of the African continent through the second vice presidents. And we had 123 respondents covering 23 countries. This map shows the green color, shows the countries which participated in the survey. The maximum incidence of participation was from Nigeria and South Africa. When registrants were asked if they were exposed to COVID-19 positive patients, in 47 registrants said no, and 35 respondents said that they were exposed during emergency department. But the impact on training, departmental teaching was cancelled in 43.9%, examination postponed in 57.7%, and cancelled in 19.5%. This shows the income of respondents in United States dollars. And fortunately, there wasn't any impact on the income, according to 84.6% of the participants. Impact on the clinical activity, that it was reduced in clinics in 61%, and it was reduced by the amount of 91.9% in elective surgery. The results of this global survey were published in the World Neurosurgery in November 2020. This table shows the difference between both surveys. And as we can see that in the global survey, we had a very good number of participants, 891, and 165 out of them were from Africa. And it was published in the Neurosurgical Focus, whereas the continental survey, we had 123 respondents from Africa, and the results were published in the World Neurosurgery. However, apart from these conclusions, let me tell you my personal opinion after organizing 53 webinars as second vice president and treasurer of the World Federation of Neurosurgical Societies during the COVID-19 pandemic. It's easy to tolerate a webinar for 2 to 3 hours. However, I believe that a complete scientific activity or a congress extending for 2 to 3 days, 8 days every hour will be exhaustive. I also have another important personal opinion that I believe that social events is an important part in all our activities in order to develop and maintain our friendship. We became friends because we met before in meetings. This is a gathering photo with Professor Franco Sirvadi and myself, surrounded by faculty and trainees from developing countries. It was in Ritz-Carlton in Cairo, 2018. However, there are many advantages of virtual learning. It is money saving, and so it's suitable for developing countries and sub-Saharan Africa. It's time saving, and this gives the opportunity for eminent faculty who don't have the time to travel overseas to educate our young neurosurgeons. It's easy for them to join a virtual learning or a webinar, and it is easier for them to contribute. However, it is not still considered to be the proper way of developing neurosurgical skills, because I think neurosurgery depends mainly on developing skills. We still need the cadaveric labs and the hands-on workshops.
2 minutes, Dr. Rando.
I took now 10 minutes, 36 seconds.
No,
I don't know if 12 minutes or 15 minutes my talk.
No, I am checking the time. You have 2 more minutes, please.
Okay.
Thank you.
Okay. Important challenges is the credibility, the certification. Is it a proper way for the certification in neurosurgery? And coordination between the 5 time zones, because we have 5 continents. There is a difference,
Sorry,
12 hours.
Dr. Rando, sorry to stop you. You have 6 minutes according to my time. Sorry, go ahead.
Thank you very much. This was I was sure about, because I have the stopwatch with me now.
Go ahead.
Thank you, Ahmad, very much. Anyhow, I will not take more than 3 minutes. Okay, and so we still have important challenges facing the process of neurosurgical education or virtual learning. Credibility, it's important because according to credit hours, how can you become sure that the participant is practically contributing to this webinar? In order to offer him the credit hours, credibility is very important. The second thing is certification. Is this considered to be a proper way for certification or just for education? The third point or third challenge is coordination. We need coordination between events, because right now we can have overlap between different webinars occurring on the same day and maybe on the same time as well. And another challenge is coordination. There should be coordination between the 5 time zones of the 5 continents. There is difference 12 hours between Asia and Japan and between Latin America and United States of America. What does it mean? For a webinar 2 to 3 hours, there is no any problem about live contribution. But if you do a meeting for 8 hours every day, it's impossible for the faculty to participate at the same time from 2 different continents, very far from each other, in the same webinar. They have to send the recorded MP4 videos to be presented. And this will take from us a very important privilege, which is the interaction between the faculty and the trainees. Discussion is very important as well in all our activities. In conclusion, COVID-19 is considered to be a turning point in neurosurgical education. It's the actual beginning of the virtual learning. Virtual learning cannot totally replace real meetings. However, it can be used as an alternative method in any future crisis. We are now well trained to deal with this new modality of education. The long-term impact of virtual learning on neurosurgical education is not yet evident until now. However, it seems that virtual learning and in-person learning soon will be integrated together in a new method of education, which we call it the hybrid meetings. With my team, I'm glad and honored to purvey the first global survey, to run the first global survey about the impact of COVID-19 pandemic on neurosurgical practice. This is another survey, not on neurosurgical education, but on neurosurgical practice. And we had very good participation, and it was published in the Neurosurgery. let us not forget our brothers and sisters who lost their life due to COVID-19. And I am honored to be one of the contributors of this publication in the Neurosurgery, which honors our neurosurgeon colleagues who lost their life while fighting against COVID-19 pandemic. Let me end my talk by sending our prayers to all of them to rest in peace and to be in heaven. Thank you very much.
Thank you very much, Professor Nasser, for this excellent presentation. Two things I have to restate. Congratulations on your contribution to the international education. And nobody exceed the 53 webinars during this time since the inception. And more important, the research you have done and publication that complement this hard work on education by giving facts and surveys and involve international community, not only your team in this survey. Congratulations again.
Thank you very much. Thank you.
I'll move to the next speaker. It will be my privilege to ask Professor Francesco Thomas. He is now with us. I'm seeing him.
Of course.
And he will, good to see you. And you have 15 minutes, and he's going to talk about the facilities regarding neurosurgical technology and education in low resources setting, and another complementary subject on this issue of education. Professor Francesco.
Thank you, Imad. Thank you, Imad.
We see your screen.
Okay. I thank you once again, Imad, and I thank Vladimir Benesh for inviting me to attend this webinar, which is honoring a good friend, Franco Servadei, as president of the World Federation and as our friend. Thank you so much for this invitation. My presentation is dealing with the neurosurgical technology and education in low resource settings, a global challenge. This is a topic which was and is of great interest for Franco Servadei, not only from scientific point of view, but also as a topic of his policy during the presidency of the World Federation. I would like to remind my commitments and those of Franco Servadei in the World Federation are before this date, but the date of 2015 with the interim meeting which was held in Rome was the date, was important date, because at that date Franco Servadei was elected president of the World Federation. And I continue to work with him also in other, for several events and in different occasions. So I am indebted to him because he is really driving also Italian neurosurgery. I would like to remind this important paper of several representatives of the World Federation, including, of course, Franco Servadei, evaluating the case volume and the neurosurgical deficits in different continents around the world. As you see in this paper, the greater neurosurgical deficit as a need for neurosurgeons is in Africa and in Southeastern Asia. And it's important to know that World Federation and the Young Neurosurgeons Forum organized a survey in high-income, low, middle-income, and low-income countries. A survey just to know what are the facilities, the technical facilities for different centers in the world. So if you look at the low-income countries, the magnetic resonance was present in 67% of cases, but you have to know that the percentage of respondents of these countries was very low. And geography was 10%, but especially it's important to note that operating microscopes, image guidance systems, and high-speed rails were, of course, a very low percentage. And in this paper, including also Franco Servadei, but many representatives of African neurosurgery on the situation of sub-Saharan Africa, shows that only 1 of 3 neurosurgeons has access to surgical microscope and lack of timely imaging. Anyway, neurosurgical availability in sub-Saharan Africa is significantly improved over the past 2 decades, but a focus on affordable and low maintenance technology is needed. If we look at the neurosurgical devices market by region, you see that we can expect in 2020-24 an increase of the market for North American from Europe, also less for Asia Pacific, but even less for the rest of the world. So the problem is that we need to understand this important aspect. Excuse me, I have to change. This important paper of Key Park proposes some suggestions for the global neurosurgical community. What to do? To promote innovations that are practical and cost-effective, and procedures such as endoscopic third ventriculostomy, along with low-cost shunts, which help reduce the barriers to hydrocephalus treatment in these low-middle-income countries. Also, some innovative, simple stereotactic systems coupled with the smartphone and tablets for the surgical safety and accuracy in neurosurgery. But if we look at the market of CSF devices, we see that the Middle East is, the time is 2017, the Middle East and Africa held least share in the global cerebral CSF management devices market. So this is the situation. We have to face this situation for the global neurosurgery. But there are also some innovations, as for example, this one, which is a combination of smartphone technology and endoscopy. This innovative use of smartphone may have a significant impact in underserved areas and may be helpful for treating patients in those areas. The World Health Organization in 2016 evaluated ways for improving access to medical devices through local production in 4 countries in Africa: Ethiopia, Nigeria, Tanzania, and South Africa. But the conclusion was that only 13% of manufacturers are located in low middle-income countries. So we need to support new low-cost innovations for surgery. And if we the barriers to access to medical device in low resource settings, the answer is very easy. Cost of medical devices, lack of properly trained staff to maintain device and to operate device, underdeveloped infrastructure, limited local production. This is a conclusion of Lancet Commission on Global Health Technologies, which states that we need more frugal technology just to face this great challenge in the low-income countries. But we can't forget the extraordinary efforts of the World Federation Foundation. Till December 2018, has dispatched a total of 241 neurosurgical equipments, and most of them in Africa, 125. Now, 3 years later, this figure is of course is increasing. In general, problems with the medical equipment in low resource settings are, as we expect, human resources, environment, material resources, and especially, particularly, educational resources, capacity to train the workforce. So I think that it is essential, this letter of Robert Dempsey, saying that the goal is to develop and maintain a self-sustaining service of neurosurgical care, which can be met by service through education. Education is as mandatory, is the important target for our action in fusion. The final remarks on the technology is that cooperation with inventors, sparring them to design, develop low-cost neurosurgical technology and devices, and most importantly, theoretical and practical training in the clinical implementation of the neurosurgical equipment for local workforce, neurosurgeons, nurses, technicians, engineers. International large-scale collaboration for training is the best way to overcome the gap between the neurosurgical equipment demand and supply. I would like to emphasize the role of the World Federation also in this with the Rabat Reference Center for Training African Neurosurgeons and the efforts of the Education Committee of World Federation. Also, the Newborn Mediterranean Association of Neurological Surgeons founded by Naja El Abadi a few years ago. This was the last, unfortunately, the last meeting of this association because afterwards the COVID time did not allow to have another meeting, and my friend Nasser El Gandour has, of course, some problems with the organization of a new Congress. And you see that in this meeting, there were several courses for young neurosurgeons of African countries. But it's impossible to forget the several meetings, online webinar for educational purpose, always with a great idea in mind, as in this case with bridging the gap, as in this case with Nasser Gandour, overcome gap between low middle income countries and income countries. And it's impossible to forget the great role of this neuroanatomy committee with 14 webinars for educational purpose. But also many other, I apologize because I don't forget no event in these 2 terrible years, but this is Asian with the World Federation of Skull Base, this is the Southern Eastern Initiative, and this is the Neuro Complications, which is, I remember, a committee of the World Federation. Of course, also other organizations organized online events just to be connected with young people and with their education. You see the CNS, the WNS, the European Association with online courses very often. And for theoretical education is important also to mention the Neurosurgical Atlas, which is a collection of advanced microneurosurgical techniques. And once again, the Young Neurosurgeons Forum of the World Federation organizing webinar to connect and to reach neurosurgeons all over the world. The inaugural webinar of this series was held and delivered by the World Federation President Franco Servadei. Another initiative is the Neurosimulator of the Upsurgeon 1, and this was published in the international literature teaching in low middle income countries beyond the frontiers of traditional education. We needed to change our paradigm in education using so many in different ways the online connection. But also important are the practical courses. Of course, the cadaver lab dissection courses were decreasing for obvious reasons, but there are also other means for practical courses as physical models or haptic computerized simulator that are growing in the general practice. Already in 2013, Gasco said that the cadaver dissection, physical models, and haptic computerized simulators have a role in different stages of learning and should be considered in the development of curricula. So the hands-on courses of World Federation, there is no discussion about this. The physical model. Some physical model may be helpful, as for example, the endoscopic and the nasal drilling techniques by this kind of simulation, or another simulation for brain tumor resection with a realistic model with easy accessibility. Or another one is anterior cervical discectomy and fusion simulator, which can be helpful for young neurosurgeons to learn about this technique. But the Upsurgeon already launched a new program funded from European Union with a small box with a realistic brain and the dura mater and the vessels, just to train young people. And many courses were of this kind of simulation were held in different countries around the world. Just to finish, virtual reality simulation in neurosurgical training are adopted in Weill Cornell University in New York, and Antonio Bernardo published his experience with these new tools for education. And also the simulation with the virtual reality and haptic interaction, which is very important, as for example, with the simulation scenario, including the bulking, hemostasis, and the micro dissection, or the best experience in Milan with the digital simulation of aneurysm clipping, just as in the reality is. But to finish, I would like to remind the important scientific contributions that Franco Servadei delivered to the international neurosurgical community in the last years. I don't want to mention all the papers he wrote on these aspects, and this means that Franco Servadei used all his efforts to promote neurosurgical education in the world community, and we are indebted to him for these very important efforts. Thank you so much.
Thank you, Francesco, for this very valid paper and covering the whole aspects, new technology as well, and how we can improve education internationally. I move to the next speaker. I may ask Professor Sanjeeva, is the Galapagos presentation valid, can be or cannot be? She has apologized. She cannot attend in person. She sent a video, but we have difficulty with the presentation. And I don't know.
Yeah, I'm sorry, Imad. We are unable to play the presentation.
We are unable to give a presentation. It was sent as a PDF. I will ask for the next speaker, Professor Stefan Florian from Romania, and he has been always a supporter of international education, and he joined us in several webinars from Romania. Professor Stefan, the venue is yours.
Thank you very much for the invitation. It's a great honor for me to speak in this webinar honoring Professor Servadei. So my thought, knowing that Professor Servadei has a large interest in neurotraumatology, I thought that it's more appropriate to present a brief history of the role of neurotraumatology in the development of neurosurgery. So I will only mark some important point in the development of neurotraumatology, and I will try to be in time. So the history of surgery in traumatic brain injury is correlated with the history of humanity. Neurosurgery is one of the oldest professions of the human race. Proof of human intervention on the skull exists since more than 12,000 years, and whatever the reason, therapeutic, mystic, or religious, there are clear arguments of high rate of survival on this neurosurgical intervention. For a long period of the development of neurosurgery has neurological with the treatment of head injuries. There are many proof that even in the Neolithic period, so approximately 10,000, 12,000 years ago, up to 3,000 before Christianity, there were many operated skulls all over the world. So here you have a map of Europe, and more than 1,500 trepan skulls were discovered up to now. It's worth a mention that the greatest number of trepanation have been excavated in France, and there it's a location, Seine-Osman region. It's considered a real neurosurgical and maybe the oldest neurosurgical center in Europe. So in Romania, we also have some discoveries, interesting discoveries. The skull from Livezi-le-Baia from Bronze Age. It's the largest trepanation with signs of survival found in Europe. The techniques mentioned by the historians are scraping, grooving, boring, or cutting, and they also develop some surgical instruments like flake stone, flint, obsidian, and bone. Many ancient authors mentioned that these trepanation were performed with a therapeutic goal, like Broca, Horsley, but even today, nowadays, the Kisi tribe in Eastern Africa performed trepanation to alleviate headache after a blow. Other hypotheses are magic therapeutic or ritual, but whatever the reason, these skulls provide a vivid picture of the enormous surgical skills of our neurosurgical forefathers living 5,000 years before modern neurosurgery began. In ancient Egypt, the earliest known practicing physician was Imhotep. He also was an architect. The earliest painting depicting cranial surgery was discovered in the tomb of Bani Hassan, and the Edwin Smith papyrus is the first trace describing the treatment of patients with traumatic brain injury. It's very interesting that these are the first description of the brain, of contusion, the dura, and the CSF intracranial pulsations. They noted, and the structure of the case presentation remind the sequence in this publication. The therapeutics options were generally limited, but they were the first who described that in severe TBI, the head should be elevated. There are no surgical indications, even in the presence of depressed head skull fractures. But as we know, in ancient Peru were performed more trepanation than in the rest of the ancient world combined. They had also motivation, but certainly there is a strong therapeutic motivation, but also rituals. They described and build up some specific instrumentation like chisels tumi, which was considered initially to be used for skull opening. It's in fact only for skull, skin opening, bone elevator, dura protectors, and hemostatic wool tourniquets. The Circas, the Incas, our ancient fathers, Inca surgeons, Circas, demonstrated good knowledge of the anatomy. They preserved the sagittal sinus and understand the role of surgery, decompress the cranial fractures, and remove pathological intracranial collection. But not only that, they also restored the normal anatomy. They performed the first osteoplastic craniotomy and also cranioplasty. Their survival rate was amazingly high, up to 70%, and there was a little instance of infection. Coming closer to our time, the Hippocrates was considered the father of the modern neurotraumatology. In his volume Periton and Cephalitraumaton about head trauma, he performed the first systematic approach of the head injuries. And this knowledge influenced the neurosurgery for 25 centuries. He described the cranial anatomy, and he was so meticulous in describing the systematic approach of traumatic brain injury that some authors also could describe a Hippocratic algorithm based on his writing. He considered that it was considered that medical history is the fundamental tool. Assessment was based on clinical examination, and he described that convulsions and hemiplegia are contralateral to injured side. He described also 5 types of fractures, and in significant injury, trepanation with terebra was indicated, and also he developed some terebra for children, so instrumentation for children. Another important personality in the history during the Roman Empire was Gallant of Bergamon, and his writings were unchangeable medical dogma for 1,500 years. Even the errors were transmitted. He argued in favor of elevation of depressed skull fractures with hematomas and comminuted fractures, and he recommended continuous irrigation during trepanation, and very important, dura should never be violated by the trephine. Coming closer to the Byzantine period, Paul of Aegina was the most important personality. He wrote Epitome of Medicine, 6 books. In the 6th book, chapter 19 was dedicated to neurotraumatology. He describes 6 categories of skull fractures, and also very important, he described the specific symptoms. and association of neurological symptoms to brain compression. Very important, he developed the method of treatment. He proposed a staged trepanation and proposed, very importantly, some neurosurgical instrument. Very important, it's that the fact that we should follow the patient, and the postoperative period was also very important for the treatment. Many of the knowledge of that period was transferred due to translation of the Ibn Sina, Avicenna, and in his writing, Canon Medicine, it was an encyclopedic effort based on the writing of Gallen and Hippocrates. And due to his effort, the Greek influence was transferred to the 18th century. He treasured all the knowledge in that period, translating and preserving for the centuries. And he provided highly systematic knowledge of head traumas. And regarding the treatment, he was a real successor of Gallen and Paul of Egina. Another important figure in that period was Al-Bukaziz al-Zahrawi. And in his treatise Kitab al-Tasrif, 30 volumes of medical encyclopedia that remained he was considered the greatest surgeon in the Arabic period. On surgery and instruments, on 3 volumes, he largely developed instrumentation for neurosurgery also, and he was also influenced by the writings of Hippocrates, Galen, and Paul of Egina. During the Dark Ages in Europe, all the knowledge was transferred to the Arabic world, but in the Middle Ages, the school of Salerno was the school who translate in the Latin language all that knowledge. So that's why we know nowadays, and it was allowed the development of medicine in Europe based on the translation of these writings. So Constantinus Africanus was the first who introduced the scholarship of Islamic Arabic medicine in Salerno, and he provided the earliest transfer of this knowledge. Roger of Salerno, from the same school, introduced the Valsalva maneuver to detect the post-traumatic CSF leak. He introduced also a not very acceptable concept of laudable pus. But during the Renaissance, the most important medical personality was Berengario da Carpi. He combined his medical experience with engineering knowledge in his treatise Tractus de Fractura Calve Sive Cranei. The first book, it was the first book on head injuries. He described the physiology, diagnosis, and treatment of head injuries, and based on his personal experience and on the entire classical and contemporary literature. Very important, he described types of fracture, but he was the first who described the anisocoria. One eye appeared less large than the other. And he also described the contractile lesions and recommended the emergency in the first hours in a patient with little sensation. He was the first who performed a surgery for posterior fossa trauma in Lorenzo de' Medici.
You have 2 minutes, Florian.
Yes, I will go a little bit faster. During the Renaissance, Ambroise Paré, in 19th century, there were other important figures, but I will go a little bit to the end of my presentation. So in the pre-modern neurosurgery, Victor Horsley Leopold Ollier and William McEwan were the most important figures. Ernst Gustav Benjamin is considered the father of modern neurotraumatology, and we also have some contribution during this history. What I want to mention that also the world wars had an important development to neurosurgery. Cushing was considered the initiator of some development in neurotraumatology, but they were already introduced by others. The first war was the moment in which the neurosurgery was developed as a subspecialty. During the Second World War, neurosurgical training consists in 4 to 6 months, and they developed the mobile neurosurgery. Other wars introduced the triage, the CT routine, CT examination, and in Iraq and Afghanistan conflicts, early decompressive craniectomy, endovascular treatment, and studies of post-traumatic vasospasm. In conclusion, only the man who knows exactly art and science of the past and present is competent to aid in its progress in the future. Since these very first attempts by Neolithic humans, surgery of the brain and discoverings has evolved slowly during some 12,000 years, with elements of refinement in the instrumentation, but with similar end results. Paradoxically, the evilest part of human personality, violence, has had a major contribution to the emergence and development of the most delicate and precise surgical specialty, neurosurgery. And the take-home message is: history is a chain of significant moments, but behind every single moment, there is at least a great personality. In the last 4 years of global neurosurgery, his name was Franco Servadei. Thank you for your attention. Thank you, Franco, for your contribution to the development of neurosurgery worldwide.
Thank you so much.
Thank you, Florian, for Stefan, for this wonderful presentation. It's very difficult to trim history in 15 minutes, but I understand, but your final slide is very valid. I move to the next speaker. We have Professor Vladimir Benish with us now, and he's going to give a very interesting talk about anatomy of consciousness. Vladimir.
Hello. Hello, everyone. Let me share the screen.
Yes, you are on.
Okay. Hello, everyone. I'm sorry for being a little late, and I just would like to greet all of you, and especially Franco, who really did a tremendous job over the last 4 years, Franco. That you must be exhausted by now. And I suppose that you will take some rest in the future, but keep and be involved in WFNS for future. I have a difficult topic. I got interested by consciousness many years ago as a young resident. And as of now, I'm not any smarter than 40 years ago. There are many aspects of consciousness as a global brain function. So I shall keep only to some definition, which probably is the most difficult task to define consciousness. And then I shall go to anatomy and medicine, nothing else. But let's see the Cambridge Dictionary and Oxford Dictionary. They both have rather similar definition, that it is the state of understanding and realizing something, of being aware and responsive to one's surroundings. It means inputs go in, they are processed, and outputs go out. But we all have a feeling that this is not really the best of definitions. And we cannot define anything with using the same word, you know, define consciousness as not being unconscious. It's impossible. Then there is this Webster Dictionary, which is a little more exhaustive, but again, it's rather similar. The first who used the term, or who used something like consciousness, was René Descartes. He used the term conscientia, the way modern speaker would use conscience, which is not really consciousness, but what he was talking in his search after truth was really what we now would understand as consciousness. And he was also the first to have some atomical correlate of consciousness. This was little funny from nowadays knowledge, but he put it into the pineal gland, which is like a parietal eye former, and from there to immaterial spirit. The immaterial spirit is always somehow entering all these definitions of consciousness, but it's probably not true. René Descartes, of course, was wrong with his pineal gland. See this meningioma in the region, see it after surgery. There is no pineal gland at all, and the patient is still fully conscious and fully capable of any activity. One well-known Jewish philosopher, Jakob Richter, failed in definition of consciousness. He tried that, but he failed. Unfortunately, he didn't fail in his other endeavors in Russia and later on globally. Almost any philosopher you would find in any dictionary tried to define the term, or someone hit the problem. What we understand as consciousness is that we are being aware of doing something. These two guys do that on a lower level than the consciousness. They don't think really about every movement. They do it automatically. It is the same way as we drive a car. You can think about whatever you want and you drive car very automatically, despite the fact that it's very, very complex activity, like Federer playing ticket. It's very, very comprehensive, but he doesn't think about how he's doing that. So there are several levels. So we could ask if the attribute of consciousness is vigility. Probably we all would agree that it is, but what about sleep? We have dreams, and dreams seems like fully conscious endeavor. So that's the first question I'm still having. Is the consciousness attribute of activity, or is it vice versa? Again, this is something very difficult to establish and something very difficult to think about. What about the intuition? We all have some intuition. The children don't have intuition. So intuition probably is something like a concentrated experience, which unconsciously the brain gives you the resume. The solving of the problem comes immediately into your mind, but the brain must process it. So it's something which, again, is not on the level of consciousness as we understand it, but in a way, it's a fully conscious event. So what I think is that we understand consciousness by intuition and by emotion. We all know what we are talking about, but we are unable to define it. It's in a way an abstract, not the concrete term. Let's go to there was even a philosopher, Stuart, who has written that there was lots of articles and lots of books written on consciousness, but that nothing of it is worth reading because we are unable to define the term. There were quite a lot of people who tried to localize the consciousness. Like this guy, Logothetis, he put it into the hope, which we all feel that it's completely wrong, but there is something behind it. It's inputs, processing, and outputs. And temporal lobe with its Mayer's loop of abstract definitely is involved, and definitely it's the most important source of information for anyone. Then there were another two guys who did into the superior sulcus. It's probably misspelling, but in the article, definitely sulcus written, and temporal parietal region. These are these areas. We all understand that this is the Broca area, this is the superior temporal gyrus, and of course the Wernicke's area. Again, it's based on a word as a symbol. See, we can resect the whole temporal lobe, the whole insula, and the patient still is fully conscious. So there probably is something more to it. Another authors put it into the primary visual and primary auditory area, which are actually very small. Even taking the secondary areas, it's not enough. So this probably again doesn't fit into the model of a real global function. Oregon put it into the sensory motor area, which is again rather restricted part of the brain. Tononi and Massimini had this zip-zap technique in defining. They stimulated the various areas of the brain. They measured the potentials and see that they put it into the parietal occipital region, the consciousness. They even have neuronal correlates of consciousness, which is something very specific for their work. But again, the whole rest of the brain is left out. And again, this is more or less dependent on visual inputs and on where there's a symbol. See, again, we can resect quite a lot and nothing really happens. Conversely, we have prefrontal cortex in humans along with the areas of Wernicke and Broca, very enlarging. It's already not in the frontal lobe. And we may understand that there are some qualities of consciousness in the frontal lobe, but not the consciousness as the whole system. See the huge meningioma with the frontal lobe completely destroyed, almost nearly bilaterally. This is after surgery, and the lady is a nurse of one of the largest departments in our country and functioning completely normally. You all would remember Egas Monitz and Norman Freeman, who was doing leukotomies like crazy. You know, I don't know the exact number, but those were some thousands of leukotomies. Fortunately, he was a psychiatrist, not a neurosurgeon. And see that the result was complete disconnection of the frontal lobe. The patients were not unconsciousness, but they were different, definitely different. So the qualitative state of consciousness was altered by this surgery, not the quantitative. Fortunately, it ended with the film of One Flew Over the Cuckoo's Nest. Then we are coming to the next theories, recurrent thalamocortical resonance, which already involves the beep structures, but again see that the optic tracts are passing the thalamus and definitely they are connected to the thalamus. So it's very, very logical, but again, I have the feeling that this is not all what is to that. And again, this is based on some external stimuli. You can operate in thalamus without any consequence for consciousness. You see where we were, removing the tumor, and here the patient who is awake, fully conscious, and in all her activities. This is probably the theory which I like best. Barnes, Dehen, they are talking about the global neuronal workspace, that if someone is conscious of something, many different parts of your brain have access to that information. On your lower left hand, you see the image when you are hearing the music for the first time and you try to understand it. You really involve lots of brain areas to understand it. On the other hand, when this is repeated, you involve only one tiny part of the brain. This is probably the same thing like with driving, like with Federer playing tennis or Schumacher driving the Formula 1. What they said, they were going from fiber tracks to networks, which is already something which is beginning to have sense in my mind. And the most likely substrate is global neuronal workspace. It means the thalamus and all the connections to the cortex and all the connections between the various areas of the brain seen on this functional MR about the music. Then comes Defoe, colleagues of us, who's not really talking directly about the consciousness. When I asked him, we hardly understood each other, but he has his theories, and he's talking about the death of I cannot pronounce it, localizationism, that we are not to localize the functions as we were doing over the whole history of neurosurgery. And here's this concepts of functional connectome and neuroplasticity, etc. But where he goes is he's coming into the dynamic interplay within and between neural circuits, leading to the concept of network. It means networks of networks, and that would be in accordance with that global neuronal workspace, and with the fact that most likely everything in the brain is redundant, that you can use some parts and you can interplay, but many parts of the brain do have access to this information. Coming to the encephalon mesencephalic border, and it's already a little anatomy, because the best we can do, and you will see it later, that we can define where the consciousness is not localized, not where it's localized. We have Bremer with his encephale isole, and we all know locked-in syndrome, that the patient is conscious but unable to respond by any movement, and if it's high enough, then he's in the let's say continuous sleep, because there is this vigility which is necessary, which is operated by reticulate formation, which is located in mesencephalon and pons, and which is very diffuse system, and which is something like a trigger for higher functions. We have all these brain connections, which we all know. We have commissures, we have associative fibers within one hemisphere, and then we have projection fibers. So those are more or less horizontal systems and vertical systems. It looks like this. This is the vertical system, corona radiata, which is well known to all of us. And these are the main commissures, the corpus callosum being the most important, as connecting both hemispheres. And within each hemisphere, we have longitudinal fasciculus, which really provides connection of one hemisphere. But we all have seen all those tractographies that everything is connecting almost with everything. Whether we need both hemispheres or not, you see the patient after the hemispherectomy and he's fully conscious, but of course those are kids with Rasmussens. So we have disturbance of consciousness, which is disorientation in time, place, person. We all know that this is already medical science, hallucination, and we all know that even from our own experience, when you are tired or sleepy or agitated by something, that's already some tiny qualitative change of consciousness. We have, of course, disorders of lucidity, which is a little bit on the side, but definitely it's underlying the qualitative state. And all this is more or less the horizontal axis of the brain, all those commissures, fascicles. Then we know that the connections probably are more important than the neurons itself, diffuse axonal injury. This is the normal subject, and see all the connections within one hemisphere or both, and see after diffuse brain injury that the neurons are surviving, but the connections are severed. And it means that in these patients, we usually see the most severe disturbance of consciousness.
2 minutes.
Yeah, I'm nearly done. This is just the picture of that. Consciousness needs vigility, lucidity, it has its capacity, diagnosis, and self-awareness. This is a combination of medical and philosophical, more or less. Then we have qualitative disturbances. This is the horizontal axis, hallucinations. So this is probably the same I've been talking. And we have quantitative, which is more or less neurosurgical entity. We all know Glasgow Coma Scale, which is, let's say, one of the best inventions we ever had. This is Graham Teasdale, and he got his knighthood for Glasgow Coma Scale, which is completely right. So we may be talking about the disturbance of consciousness when we are between 6 and 14, and coma or unconsciousness is between 3 and 5, and it means that we are getting lower than the thalamus with this lower point. To conclude, consciousness at its simplest is awareness of internal and external existence. But again, it needs some more precise definition from philosophical point of view, not from medical. Intuition that it exists is what we all have and what we all understand. And we somehow even understand the term. We know what the consciousness is, but we are unable to define it properly. From neurosurgical point of view, consciousness is reduced to Glasgow Coma Scale. It's easy, simple, and very, very international and very perfect. There were many books published on consciousness. Probably the one on the left lower corner is the best because the best, difficult to say, but there is a combination of philosophy and neuroscience. Altogether, probably 40 captures about both. And should I recommend something to read, it would be this one. Thank you very much for your attention, and I don't think I helped to solve the problem.
Well, thank you very much, Vladimir. Very intellectual presentation, supported with a lot of science innovation. We are waiting for the next Nobel Prize holder to come with this, to answer this one. Great presentation. This is the first I'm hearing you talking about it. Now, I think we conclude the first session, and I'll give the moderator to Vladimir, and he will be helped with Professor Igor Maldonado to take the vascular session. Vladimir, the venue is yours.
I believe we can start immediately. So,
yes.
Igor,
Yes.
are you with me?
Yes, I am here.
Very good. So I take first 4 and you'll take another 4. Is it fine by you?
Just 1 minute.
Yes, sir.
I have to tell you, Anil has apologized this morning. So Anil's presentation is out. We have Professor Kato. She has sent the video that was tailored, and I hope it will work. So they will try it. My colleague, Professor Sanjeeva and Pablo. Thank you.
All right. All right. So let's start with the first lecture, which is our very good friend Suresh Nair is going down memory lane, significance of Sylvian Triangle. Suresh,
thank you. Yeah, is my slide visible?
Your face is visible, not the presentation.
Okay, 1 minute. Let me try again. 1 minute. 1 minute. One minute. Let me share again. Share screen.
The green button.
Yeah, green button. I have pressed.
Share screen. Then you will see your screen and the presentation on it. Share again.
Yeah. Are you seeing now?
Yeah, just go to the presentation mode.
Yeah, I will do that. Okay. Okay, fine.
Very good. Very good. Go ahead.
Thank you. At the outset, I should thank Professor Imad and Vladimir for inviting me to be a speaker for WFNS Anatomy webinar, which we are holding to honor our past WFNS President, Franco Cervedei, who led us from the front during these difficult COVID times. There was an explosion of webinars which brought world's best to our living rooms, and those stalwarts were just a click away. We are still going through difficult times, but as Robert Schuller puts it, tough times won't last, but tough people do. With this short introduction, let me start. And some of us who have had training in neurosurgery from 70s, they may like it, but the last 5 talks are highly technical. So let me start. Yeah. So the position of middle cerebral artery and its branches in lateral angiograms had considerable importance in the diagnosis of tumor of the cerebral hemisphere. And in nearly 80% of the case, the position of a suspected tumor could be derived from angiography. Neuroangiography continues to be an important armamentarium in the diagnosis and treatment of patients with neurological disease. But advances in cross-sectional imaging, that is CT and MR, and in non-invasive vascular imaging like ultrasound, CT angiogram, and MRI have supplanted the traditional applications of routine neurodiagnostic angiogram. Presently, the indications of neuroangiogram range for diagnosing and treating extracranial diseases, as I have listed, 2 intracranial diseases like subarachnoid hemorrhage, AVM, spasm, acute stroke, so on and so on. So now we are going back to the future. That is, even though the first CT scanner was installed at Atkinson Morley Hospital in 1971, it took nearly another 10 to 12 years for it to become freely available for a diagnostic purpose in many countries. including India. So diagnosing an intracranial tumor continued to be by pneumoencephalography, contrast ventriculography. These were very uncomfortable both for the patient and in many instances for the neurosurgeon himself. So brain tumors supratentorial were diagnosed by direct puncture, carotid or retrograde transfemoral angiography, and approximate location of the tumor was assessed by looking at abnormal displacement of intracranial, carotid, and sternal branches, anterior and middle cerebrals. When I started my training, this was the only book available, Northfield. Later, 3-volume Yeoman's Cave. And there was another textbook by Matson and I forgot, there's a pediatric neurosurgery textbook, Ingram and Matson. There was another textbook available, and we didn't have any textbook. This was told by Vladimir. This man, he not only did frontal leucotomy, did the first cerebral angiography, and he, along with the other two, Almeida Diaz and Almeida Lima, described the topography of Sylvian artery. And later it was Crayanbull and Richer and Lasartos. They described details regarding MC, middle cerebral artery, description of insula, so on and so forth. But it was a German neurologist who described, by name Schlesinger, who coined the term Sylvian Triangle. Thanks to Joan Tavares and the great Albert Rotten and Anne Osborne, we are better off with the anatomy, which explored the last 4 decades. We know the Petrus carotid, lateral carotid, cavernous carotid, clinoidal carotid, ophthalmic, and communicating segments in detail, not to mention about this middle cerebral artery. So it was also described by sphenoidal segment, insular segment seen here in yellow. Then you have the opercular segment with courses around the opercular to become the cortical segment, and how these are projected on routine AP angiograms. We know the branches of middle cerebral artery. We know the various perforating branches. We know the anomalies, and we know about anterior cerebral artery also in detail, because all these tumors had some bearing on anterior cerebral artery displacements also. So we know anterior cerebral artery, communicating artery, and its branches also, and the various anomalies of anterior cerebral artery as well. And also we also knew in detail about the venous anatomy as well, because this also gets displaced during tumor development. And also because of the great pioneers, we know in detail about the vertebral artery, its branches, pica, basilar artery, various segments of the posterior cerebral artery, and so on and so forth. But the main thing of my talk is this publication, which came in 1964 by Tavares and Irwin. They described in this presentation the angiographic localization of suprasylvian space-occupying lesion. And later this landmark article, which came in 1968, where the arteriographic pattern of insula is normal appearance and variation seen in tumor of the cerebral hemisphere came. And we all relied on this displacement of this triangle here, which is called the Sylvian Triangle, and which I will be telling now. So here we can see the Sylvian Triangle here. This is the Sylvian Triangle. The superior border is formed by the superior insular line. And this is a line tangent to the top of the insular loops. So we can see the insular loops. So if you draw a tangent along the top of the insular loops, you get this top line. And this line here is the inferior line. Inferior line is a line through the main trunk of middle cerebral artery. And anterior is the most anterior branch, which arises, it's ascending frontal complex, and you get this Sylvian Triangle. And lesion in relation to the triangle were described like that: anterosylvian, retrosylvian, infrasylvian, so on and so forth. Here, this is posterior, this is anterior. A lesion in the occipital lobe. It pushes this is a Sylvian Triangle here. It pushes the Sylvian Triangle anteriorly. A parietal lesion pushes the Sylvian Triangle down like that. A posterior temporal lesion pushes the triangle like this. And this is a lesion very high in the vertex, they push the Sylvian triangle, and here very close to the lower down, it pushes the Sylvian triangle like this. And this is, you can see a frontal lesion and a basifrontal lesion, how it pushes the anterior wall of the insula. We also know about the Sylvian point. This is the most medial and superior point where the last cortical MCA branch turns inferiorly to exit the Sylvian fissure. And there is this also we used to rely a lot. The Sylvian point always lies halfway between a tangent drawn. If you draw two tangents, one through the inner table of the skull and other through the roof of the orbit or petrous, which is lower, the midpoint, this corresponds to the Sylvian point. And any tumor above will push the Sylvian point down, and a temporal tumor usually pushes it up. This is an important line which we always used to measure. This is called the Clinoparatal Line, which goes from the anterior clinoid process to a point which is 2 centimeters above the lambda or 9 centimeters above the internal occipital protrusion. And this is the usually the line of middle cerebral artery is 1 centimeter above or below this line. And this what angiographic Sylvian point, which I showed before in the AP film, in this lateral view lies within a radius of 10 millimeters at the midpoint of this line. So we could know the approximate location, and also the Sylvian point is 30 to 43 millimeters from the inner table, while this insular segment is 20 to 30 millimeters. And this could be depicted on a plain radiograph where we can see what is the approximate location of the insula. And you can see the middle cerebral branches also. So one can easily used to easily plan the craniotomy flap based on how this triangle is displaced. Similarly, anterior cerebral artery also a round shift, a distal shift, a square shift, and a proximal shift, depending upon when the lesion is anterior to the coronal suture or posterior to the coronal suture, or behind the foramen of Monroe in the lower half of the hemisphere, or it is a basifrontal lesion. Let us see some examples. This is a sphenoid wing meningioma. And this sphenoid wing meningioma, if you see, it has lifted the middle cerebral layer, this M1 segment up. You can see the blush, but also the Sylvian triangle. This is a Sylvian triangle. It is displaced posteriorly, and MCA is also displaced superiorly and posteriorly. So in olden days, we used to arrive at the location of the tumor by looking at this displacement of this middle cerebral artery and branches. Then this is a left sphenoid wing meningioma. Here, if you see this left sphenoid wing meningioma, this M1 segment is displaced, straightened and lifted up, and there also you can see the Sylvian point is lifted up. Then we know there is a lesion somewhere in the middle cranial fossa. This is how we used to diagnose a tumor. You think of a large meningioma, a paraphalceal meningioma. What it has done, it has produced a shift of the anterior cerebral artery. And you can see the splaying of the vessels and straightening of the cortical vessel. And we used to infer that there is a tumor by seeing this round shift and also this straightening of these vessels. And this is a cavernous meningioma. You can see this is a Sylvian triangle which is displaced up. So the branches of the middle cerebral artery, they are lifted up. Base of the triangle is lifted up. And there is an open carotid siphon. And also one can see a proximal shift of middle cerebral and anterior cerebral artery. A planum sphenoidal meningioma, see there is lifting of both the anterior cerebrals, and middle cerebral is pushed backward. Tumor blush is there. There is shift of the anterior cerebral artery. So we used to infer location based on angiogram only. And these are some of the things that this is a tumor invading the transverse sinus. This also we could infer from an angiogram. And think of a tendorial meningioma. This is a tendorial meningioma. This has displaced superior and anteriorly the middle cerebral artery. And there is abnormal vascular blood, supraclinoid carotid is straightened up. And here also we can see the displacement of middle cerebral artery and straightened supraclinoid ICA, as we see in this picture more clearly. And this is a large middle cranial fossa meningioma. You can see how the M1 segment is lifted up. There is shift of the middle anterior cerebral artery, total straightening up of the ICA, and you can see how the siphon is opened up, and you can see the tumor blush. And this is a pituitary tumor. We can see how this is how we used to infer a pituitary tumor by seeing this lifting of A1 segment of bilateral A1 segment. A pituitary tumor with suprasellar extension will give this picture. And this is a large petrotendorial meningioma, tendorial edge petrous middle fossa meningioma. Large tumor. I will skip this slide. One can see not only tumor but also the feeding vessels from tendorial artery. You can see the blush. You can again see this picture. The middle cerebral artery is lifted up. There is proximal shift of the anterior cerebral artery, large tumor blood. And also we can see, compared with both sides, we can see the posterior cerebral arteries are lifted up, and the superior cerebral artery also is lifted up. A clival chordoma, this you can see again, the displacement of the basilar artery. We can see the superior displacement of the left PCA. And also these other tumors like hemangioblastoma, nicely one could infer from an angiogram. So my conclusion, diagnosing brain tumors prior to CT era was not easy. Present day indications for angiogram for intracranial tumor is not for diagnostic purpose, only for embolization for hypervascular tumors to see vessel patency and cross circulation in cases where tumor has encased or engulfed the arteries, to study the venous anatomy in selected cases. So my last slide, even though diagnosing brain tumors by angiogram is bygone, dead, defunct, departed, expired, extinct, gone, vanished, but old is still gold, yesterday, today, and tomorrow. Thank you. Thank you very much, Professor Imad and Vladimir, for giving me this opportunity.
Suresh, thank you. That was great. I can tell you that I sometimes miss angiography. It still gives you some information which is useful, but as you said, it's old and not used because it's invasive. But I miss it. Okay, let's go for another lecture, which is Asra Al-Fawzi, Neuroangiography Patterns and Anomalies of Middle Cerebral Artery. Asra, are you with us?
Yes. Thank you, Professor Benes.
Go ahead, please.
Can you hear me? Okay.
Yes, yes.
Okay. Thank you, Professor Benes, Professor Maldorando, and also my friend, Professor Imad Kanan. Let me share my screen. Okay. Can you see my screen?
Yes.
Vladimir? Okay.
Yes.
Thank you.
Go for presentation mode. Yes. Perfect.
Okay. Thank you. And once again, thank you for inviting me to join this great webinar honoring our great teacher, great mentor, Professor Svadi. And this time I will talk about the neuroangiography patterns anomaly of the middle cerebral artery. I think this is mostly a basic science and also, very important for young neurosurgeon to know the basic anatomy and some variation of the MCA. As you know that MCA is a very important vessel in our brain because this is the largest and most complex of cerebral artery due to significant development of the cerebral neocortex in humans, and it covers a large part of the cerebral hemisphere. And sometimes even we operate on tumor or another pathology, more specifically for some vascular lesion in MCA area. So it's always exposed during our surgical intervention. And also aspect of its cerebral branch tend to vary. This is very important that we have to know. And yes, of course, actually, there are many, report or publication a long time ago. This is from AGNR in 1973, but they report the anomaly of the MCA, and that time maybe mostly the purpose is just showing the knowledge or the basic knowledge about the anatomy of MCA, and then how it has some anomalies too. But I think in a modern area like this, with advance of microsurgery, advance of the radiologic examination, so I think the important thing to know the MCA anatomy is is very important, because the broader aspect of our surgery make it we have to know this this artery. Yes, I think already mentioned by Professor Nair that the MCA is the vasculature of the MCA includes some of the most eloquent cortical area for motor and sensory function, the receptive and expressive language, abstract thought, and other faculties of higher cognitive functioning. So, and the perforating branches of the proximal MCA supply the basal ganglia and also important descending and corticospinal tract. So I think, it's very important to know that in our surgery, we have to respect this artery, because if we damage or make some big complication to our patient. And Van der Zwaan that time have demonstrated that there is enormous asymmetry and inter-individual variability in the cortical and subcortical territory of the MCA. So we know that even this is even anomaly or some different diameter, another thing, but even in inter-individual variability is always happen. This variability is directly related to the proximal diameters and also peripheral resistance of the major vessels. And yes, as mentioned earlier by Professor Nair, that there are 4 segments important we have to know of the MCA. First, we know M1, sphenoidal segment, and M2, the insular segment, M3, the opercular segment, and also M4, the cortical segment. Each has some implication of our neurosurgical practice. For example, M3 and M4 may be very important anatomy that we have to know if we did the bypass surgery. And the sphenoidal segment, sometimes we have to know, because they are arising, there is very important perforator branch, lenticular artery, and M2, the insular segment, if we are dealing with some pathology in insular, so we have to know this anatomy. And also the anatomical variation of the MCA have to be recognized when planning intervention in order to avoid damage or occlusion of the perforating vessel that arise from the MCA, and to assess their contribution to the profusion of the deep MCA territory. I will show you some paper of mine and other paper that the MCA anomalies are often mentioned in the literature, although the subtypes are really elaborated on. Variants of the MCA represent a substantial risk for misadventure during endovascular embolization or blind navigation during treatment of asymmetric. I will show you some report of this. Yes, I think this is I have a source from the literature that the base length of the main trunk is divided into three segments. First, short segment is 3 until 12 millimeter, medium 13 until 22 millimeter, and long 23 until 40 millimeter. It's about M1. And also early branching is very important too. if branching occurs within 5 millimeter from the MCA origin, so we call it early branching. And you can see from the picture here, there are many branching patterns: monofurcation, tetrafurcation, pseudo-tetrafurcation, medial bifurcation, lateral bifurcation, medial pseudo-bifurcation, lateral bifurcation, 8, trifurcation, pseudo-trifurcation, and proximal trifurcation and distal trifurcation. You can see in the picture many variation of the branching. And I published my article here about neurological pattern of middle cerebral artery in our hospital. You can see there we have some data for short segment is mostly short segment of M1 is about 42%, and early branching only 6%. So very quite little number. And also for medial bifurcation is mostly in 46%. Lateral bifurcation in 12%, and for trifurcation is only 9.4%. So this is a number from our data. And also you can see here, this is the any neuroangiograph pattern from our data, short segment and medium segment, and also long segment. And early branching, you can see earlier that early branching only about 6% in our data. So yes, how is it have implication to our neurosurgical practice here? For example, this case with maybe a relatively long segment. So actually aneurysm lie down, more distal and near the cortical surface. So sometimes if we open up the Sylvian fissure, we can directly see the aneurysm. And also with the long segment of the M1, we can see maybe easily or clearly the M1. So if we can put some, temporal clips, so easier to put in the distal part, so we can avoid to injure some perforator or branching that specially arise from the proximal part. So this is some implication that we have to know according to the anatomy of the MCA. So the variation anomalies. Yes, I have read many literature, and there are many variation anomaly you can see here. And of course, there are some accessory, there are some duplication, there are some fenestration, and some hypoplasia or aplasia. You can see a little bit complicated, I think, in this picture, but in the data show that anomaly for accessory is 1.11% and duplication is about 3.1%. And in our data with zero hypoplasia and zero fenestration, it's a little bit different from another data that some data show some number of fenestration in high percentage. This is also my published article about systematic review about anomaly of the MCA. You can see the pattern of the bifurcation and trifurcation, pattern of branching. I see from many articles is around 70% bifurcation of the MCA, and also about 27% trifurcation. You can see from the picture here about the bifurcation and also the trifurcation pattern. So also this is my data from systematic review about the anomaly of the MCA. You can see, I don't know, we reported more number of duplication and also accessories, but another publication showed a great number of the fenestration. I don't know, maybe it's, yes, we have to make some further research about this. Is this related with ethnic or another part of the country, something like that? So this is the number. So, but in my article here, we can see that the anomaly of accessory is about 0.03%, very small number, and duplication about 0.17%, and fenestration about 0.15%. So yes, this is some how important is we have to know the anomaly of the MCA. For this case, you know, this report how they near miss how they should treat the patient, because you can see here, this is the patient with you know, clinical stroke patient. From CT scan showed and CTA showed some normal condition, but the patient have some clinical stroke condition, so they have perform CT perfusion. You can see here that there is infarct area and penumbra, and they across further for DSA. And then on DSA, they know that some, you know, branches duplication, duplicate branch was occluded. So we have to know that even with some duplication of the artery with some pathology there, they have some, you know, implication for our neurosurgical practice. So they do the thrombectomy, and you know, after that the recanalization occur. In
1 minute, Asra.
Oh, okay. And another case, so yeah, anomaly duplication. So also some multiple cerebral aneurysm with devastated pathology, intracranial hemorrhage. The duplication makes some, you know, hemodynamic consequences, so easy to rupture. And this is also the if we see some aneurysm in the middle portion of emancipation is unusual, so we have to know that there is another maybe pathology. You can see from DSA there's a long fenestration, so the aneurysm leg is lie then in the proximal end of the fenestrant part. So if we did the surgery, we have to be careful about this. Also, again, bifurcation, some trifurcation, some difficulty. We have to arrange the.
Could you please go for conclusion?
Oh, okay. This time, our conclusion is anatomical pattern and variation of the MCA have to be recognized when planning surgical and endovascular intervention. Studying the neuroangular pattern and variation anomaly of the MCA may help to plan optimal treatment strategy. Thank you very much again for Professor Franco Sevade. He came, I think, 3 times to Indonesia during his presidency. He also our honoring professor in our university, and he is a member in our family in Indonesia. And thank you. We hope you will do more and more great things in the future. We also hope that our cooperation and collaboration during this time will continue to grow. Thank you again. Once again, congratulations on your achievement. Thank you. Thank you very much. Thank you, Vladimir.
Thank you very much, Professor Alfauze. Let's go to the next presentation. And as I understand, Yoko Kato has sent the film Sanjiva, or Pablo.
Yep, I will play Professor Kato's presentation.
Okay.
It is my great pleasure to be invited this fantastic WFNS Neuroanatomy Committee, the webinar meeting. First of all, I'd like to thank you very much for the Imad Cannon and the Vladimir Menesh who are organizing a very nice webinar. So today my talk is Future Diagnostic and Therapeutic, the Strategy of Brain ABM. I would like to thank you very much the past WFNS President, Professor Franco Salvadari. His leadership was fantastic. And also that he always focused on the violence education. That we follow his step in our future educational activity. So this is one of the area, the typical or surgical strategy. So patient has associated with a large aneurysm of the pedicle IC. And the right temporal lobe location, first of all, we check the main feeding vessels. Then we place the temporal clip on the main MCA feeders. Then after that, we decided to the dissecting plane and also the definite feeding vessels which we can detect from the surface. Already we cut and then we start to dissect of the nidus. We can see there's so many the hemorrhagic parts, hemorrhaging around the nidus. Just so you can be careful about very fragile vessels, which is emerges at the last part of the surgery. It makes some post-operative the bleeding. So step by step, we reflect the nidus, and also we check the ICG. And finally, this is the final draining vein. So now we coagulate it. Usually, some parts remaining the nidus, which is hidden the final the big draining vein. So just you can check or around of the final draining vein. So this is the final situation. So we coagulate completely. So this is the final stage in the ABM resection. So the ABM has so many issues to be discussed. High grade ABM and also the elephant ABM is one of the main topics. So this is the clinical aspect. So special margin grade 3-4, the so-called high-grade ABM. If the asymptomatic patient, the observations should be the best. The symptomatic patient, the endovascular the embolization followed by the radiosurgery or direct surgery. So what is the high-grade cerebral ABM? This is a special margin grade 4-5, the large, deep, involved elegant lesions, substantial surgical morbidity, and the indication of surgery will be following the previous hemorrhage, existing permanent neurological deficit, aneurysm association, and step phenomenon, the still phenomenon, and suggest observation for the young age patient. So there are 4 or 5 modalities: endovascular and microsurgical resection, and radiosurgery observation, and also the combination treatment. So multidisciplinary approach is achieving cure of the treatment, endovascular treatment or reduction nidal size before microsurgery or radiosurgery. The open surgery, this is still gold standard of the treatment, especially small nidus. Endovascular treatment, this is adjunct of the treatment. For surgical nidal reduction, the flow reduction is main purpose of this treatment. Radiosurgical treatment for inoperable or high-grade OP. So this is how we can treat of the AVM with open surgery. So just we can check the MRI. Yeah, this is a 3D multifusion imaging, so the vein and the nidus, and also the feeding vessels. So how we can analyze these nidus. So this is one feeder, another feeder, and 3 feeders. So this is one very unexpected bleeding case during the embolization. So this is the onyx. Sometimes when we use the onyx, we should be very careful because the onyx is very slow injecting and plug and push vessel. So it's most of the case, the onyx comes with a draining vein. So that is a big reason why the nidus bled. The patient had the mild paralysis, but it improved completely. So this is we injected the nidus needed after the bleeding of the nidus with embolization. So high functional OR is so many good devices, 800 ICG, navigation, monitoring, functional OR, captography. So already I have shown. So this is a very perfect hybrid or high function OR. So this is a flow 800. So this is exactly the same phase. This is a draining vein. So it can be the orange. The orange means it's the feeder and in between the feeder and the draining veins. So we can see the intensity diagram. So draining vein can be in the middle of the feeder and draining vein. So in conclusion already I talked. The risk of the permanent neurological deficit is 40% for highly eloquent AVM, the prefrontal cortex, basal ganglia, and brainstem. The 18% for less eloquent AVM, postcentral cortex, conceptual lobe, and the dominant temporal lobe, and the corpus callosum. The 3% for non-eloquent AVM. Staged nidus radiosurgery. So microsurgery is effectively to reduce the mobility as salvage technique after radiosurgery. So firstly, that we give the patient from the radiosurgery followed by the microsurgery. This is one of the new techniques. So this is the first time, and in between the first second is wait 3-4 years, and the second third wait 3-4 years. So then finally the nidus became much smaller compared from the beginning. So this is the new treatment paradigm for high-grade AVM. So the staged embolization and the more staged radiosurgery and the reduction of the flow and microsurgical injection. And this is after radiosurgery downgrading and going the nidus and followed by the microsurgical injection. So this is the microsurgery after the radiosurgery. So this is, it has a very good result. Almost disappear of the nidus. We can recognize it's just a method. So cure rate is over 80%. Surgical mobility modality rate is 80.8%. So finally, the future diagnostic and therapeutic strategies for brain AVM. So this is a molecular and cellular biology of AVMs. It's a congenital static lesion and the sporadic cause, the growth, remodeling, and the repression, the rupture event. The new genetic, molecular, and cellular factors have been demonstrated to be involved in the process of the formation, growth, and rupture of AVM. How can biology impact the potential future management? So risk of AVM rupture, one is genetic mutations, intranidal aneurysm, exclusive deep venous drainage, and a restricted venous outflow in the deep or infratentorial location. So this is a schematic drawing. It's the molecular and cellular biology of AVM. The exposure of the abnormal, the high flow plus shear stress, and smooth muscle cell and brain and cellular cell, constant proliferation and the remodeling. So this is the four cause of the AVM minus large. So this is genetic. This is experimental therapeutics and formation and the growth and rupture. So many factors and so many cause can maybe enlargement. So molecular and cellular biology associated with the syndromic AVMs. So we can experience about the HHT or CAMS. So AVM formation. So this is a single nucleotide polymorphism, SNPS, and also the TGF pattern, and also the endocrine ENG. It's a weak protein located on the cellular surface, crucial for angiogenesis. So as for the AVM growth and rupture, the role for inflammation and the extracellular matrix remodeling. Macrophage and the neutrophils tend to invade AVM tissue. The matrix method of protein does the key role in the growth and rupture of several AVMs. Brain endothelial cells have a higher proliferation rate with a reduced apoptotic response to inflammatory mediators. Multiple mechanisms, including inflammation, remodeling, and VC abnormalities, contribute to tendency to rupture. So about AVM treatment. Part of the treatment is open surgery and radiosurgery and endovascular treatment. But completeness is endovascular is 30%, and also the radiosurgery is about 40%. So microsurgical resection is currently recommended for special bones class A or special Martin grade 1 or 2 AVMs. In combined treatment, special bones, class B or special Martin grade 3. The palliative treatment, special bones class C or special Martin grade 4 and 5 AVMs. So new treatment idea is a new cellular and molecular biological therapies are under development. It aims to reduce sensitization in the vascular targeting and the remodeling therapies. So understanding of the regulatory factors and the pathways is very important. That is modifying the natural history away from rupture. So experimental therapy, so many drugs is appearing. So tetracyclines and doxycycline and VEGF, and the focal hyperstimulation delivered by an adenovirus vector shown in the inhibition of the MMP9 messenger RNA expression. Thrombospondin 1 is another important drug. So it's anti-angiogenetic therapy, a thrombosponding one, and also the VEGF-A antagonist, Bevacizumab, is very popular one. So in conclusion, in understanding the complex cellular biology, physiology, hemodynamics, and flow-related phenomena of AVMs is critical for defining and predicting their behavior, developing novel drug treatments, and improving the endovascular and surgical techniques. So, of course, for the moment, the main treatment, the three categories, but we should think about the very basic, research for preventing the increasing of the avian virus itself. Offers conservative observation for younger patients with rupture high-grade AVMs and long life expectancy. Once there is a rupture or high risk of rupture, the surgical mobility associated with the downgraded AVMs is reduced to that of post-radio surgical preoperative supplemented testosterone increase. So sometimes we think about the radiosurgery, especially the large or the diffuse type of the nidus. You can give the radiosurgery in Dubai, especially in between the 2-3 years. That is one of the options for such a very difficult type of AVM. And thank you for your listening.
Yoko, thanks, and Sanjiva, thanks for technical help. I now shall hand over to Igor Maldonado, who will chair the next part of the session. Igor, please.
Thanks, Vladimir. For the next lecture, 3D DSA guided STA MCA keyhole bypass. It's my pleasure to invite Professor Bing Zhu. Professor Zhu, well known of all of us, is Professor of Neurosurgery in Field University, Shanghai. Please, Professor, you can start your lecture. Thanks for joining us.
Thank you, Professor Igor and Professor Kanan. So Professor Franco Savade is a great friend of mine, and we met in Africa, in Asia, in Europe, and even in China. This is a great war, and Professor Franco Savade, he sent one of his pupils to me and to learn the bypass, and he even drove 3 hours from Milan to Zurich to attend the bypass memorial conference hosted by Professor Luca Rigli. So this is my personal experience in bypass. Now I have almost 8,600 bypass cases totally in China and in India. So for moyamoya disease, mostly we adopt the big incisions like this. So normally the scalp flap is quite big because we want to achieve this kind of revascularization like this young boy. You can see the whole brain, the both hemisphere was totally revascularized by the ECA branches. And the later one, most part of the cerebral was revascularized by the ECA branches. Sometimes STA can achieve the revascularization for the whole hemisphere. So for moyamoya disease, there's 2 different conditions of the recipient MCA network. The first one is a good MCA network normally for the early stage of Suzuki stages. But for the late stages, normally stage 5 or 6, the network of the MCA was quite poor. For the good MCA network, after the direct bypass, the blood flow can reflux to the M2, then redistribute the blood flow to along the MCA networks. So intraoperatively, we measure the blood flow, use the NOVA system. Normally for the single bypass in Moya-Moya bypass, it's around 20 to 30 minutes per minute. But after 7 days, you can see the blood flow can increase to 77 millimeter per minute. Sometimes if we use double bypass, the blood volume can more than 100 millimeter per minute. So it's quite a lot. So according to the different condition of MCA, you can see in this patient, the right side, the MCA network was quite good. So this STA carry on 140 millimeter per minute after bypass. But on the left side, you can see the recipient artery was quite small. So the STA only carry on 91 millimeter per minute. So the good MCA network, you can see after the bypass, STA can increase a lot. In this patient, the diameter is 3.3 millimeter, feeding the whole hemisphere. But on the contralateral, you can see, although the bypass was also patent, but the recipient artery was very small. So the bypass was maintained quite a small size. So the condition of the recipient MCA network is a key rule to determine the blood flow volume in bypass. In patients with a good distal MCA network integrity, the main feeder is STA after operation. The middle meningeal artery and the deep temporal artery contribute little. You can see after this direct bypass, the STA enlarged a lot and feeding the whole MCA network. Although the middle meningeal artery and the deep temporal artery also have some spontaneous stoma, but it's very small. So the minimally invasive direct bypass is needed. The distal MCA network with good integrity, normally the early stage of Moya-Moya. Most of the Moya-Moya syndrome can also maintain the MCA network integrate. In this kind of patient, the main feeder is STA after operation. So many patients have psychologically resistant to large incision and the large bone flap, leading to the continuous disease progression and even loss of direct bypass opportunity in the future. So the minimal invasive approach means small incision, small bone window, and keeping the hair. So before the surgery, we can analyze the pressure change in the MCA network and the ECA branches. This is the STA. You can see the pressure decrease to the distal STA. And this is pressure gradients in the distal recipient artery, MCA, one of the MCA branches. So before the choosing the right donor and the recipient artery, this is a type 1. The donor and the recipient artery are very close at a certain position. You can see in this patient, the donor artery and the right and the recipient artery was almost at the same position. Just the distance is just the width of the bone flap. So we measuring the distance between donor and the recipient artery. It's around 1 centimeter. So we calculating the length of the skin incision and the diameter of the bone flap. The bone flap is only 2 centimeters. So the skin incision is around 4 centimeters. So this is selecting the segment of the STA between the two bifurcation landmark. This is a landmark in the surgery. So this is the recipient artery, which we want to expose intraoperatively. So this is a surgical plan, and this right side is a real surgical view. You can see it's the same. So after we calculating, and then we performed the bypass. The bypass procedure is the same as the usual one. So this is a surgical field. You can see after the surgery, the bone flap is so small in the CT. So this is another case. After the bypass, the patent of the STA. So now the distal MCA network was fed by the STA, totally replaced by the STA. The second type, there's some distance between donor and the recipient artery. You can see this is where we select the recipient artery, and this is the donor artery. So we have to move the donor artery to the recipient artery. This is the MCA network is quite good before surgery. And this is the incision under the bone flap. This is a post-DSA. You can see the stoma was quite patent and the bone flap was very small. Before surgery, you can see the MCA network, the blood flow comes from the myomere vessels. After the bypass, you can see the blood flow all come from the STA, reflux to the M1, M2. So MCA has two types. This is the first type pressure gradient of MCA, still keeping the physiological direction, which means a P proximal larger than P distal. This is a typical one, but there's second type of gradient of MCA. So in this kind of MCA gradient, it's reversed psychological direction. You can see the M2 blood flow come from the PCA branches. It's like a circle. So the P proximal is less than P distal. So there's many intermediate states. So this is after double bypass, you can see the blood flow was quite abundant. So if the delta P was quite big, so after the bypass, in flow 800, there's a red T sign, which means the bidirection fast blood flow. The delta P was quite big. So left side is this is a single bypass. Right side is this is a double bypass. You can see all is a red T sign. But sometimes if the red T is one short arm like this one, you can see that, which means delta P is barely positive. So after 1 week, you can see the STA was almost occluded. So this is a borrow case from Dr. Zhang Jianjian from Wuhan. So after selecting the right with a great delta P position and selecting the right donor and the recipient artery, the intraoperative bypass was as normal. But in this kind of keyhole approach, the positive of the brain was quite big. So this is a post-operation DSA. You can see the bone flap was very small, and after several months, you can see the size of the STA increased a lot. and you can see the blood flow reflux to M2 and totally feeded the MCA network. So because the bone window is quite small, so I designed a new set of single-arm microanastomosis instruments. So this is a new instruments. So this is a real video for the single-arm microanastomosis instruments. So this kind of instrument can use in this very small space. Okay, this is a distal. This is a long-term follow-up after the bypass. So this is a take-home message. So the targeted keyhole STA-MCA bypass is suitable for patients with good MCA network. Technically, it's feasible, and select the appropriate location. Make sure the delta P is positive, and the patient are highly satisfied after the cosmetic reason and willing to take surgical treatment in early stage of moya, especially for female patients. So this is a book edited by Peter, and this is my chapter in the for the late stage moya disease treatment. Thank you.
Thank you, Professor Zhu, for this excellent lecture and for respecting the time also brilliantly. I remember all the attendees that they can ask questions through the Q&A chat. So for the next 15 minutes, it's my pleasure to invite Professor Jack Morkos to start his lecture on bypass surgery for moya and ischemia techniques, results, and novel concepts. Professor Morkos also doesn't need any presentation. He's well-known of all of us. Somebody very implicated in vascular neurosurgery. He's professor of neurosurgery at the University of Miami. Professor Morkos, are you there? I think he's not connected. I don't see Jack Morkos. So let me move to the next lecture. So let me invite Professor Caldwell, William Caldwell. I saw Professor Caldwell was connected. Professor Caldwell, also very well known to all of us, is professor and chair of neurosurgery at the University of Utah. He'll give us his lecture on the evolution of open and the vascular interface in skull base and vascular neurosurgery. Thank you very much for joining us, Professor.
Well, thank you very much. It's an honor to be here. It's a special honor. Oh, hang on for a second. Let me see if I can share my screen here. So can you see that okay, Igor?
Yes.
Wonderful. Well, it's a special honor to do this in honor of Franco Cervede, who's a close friend and a great mentor and a great leader in neurosurgery internationally, and with a special interest in education. So congratulations, Franco. It's great to do this in your honor. Thank you. I'd like to talk a little bit about the evolving endovascular and microsurgical interface in America. And I'm sort of giving this from the aspect of an open vascular surgeon and skull base surgeon. And also I've included my endovascular colleagues who are great leaders in endovascular surgery in America, Phil Towski and Ramesh Grandi. and a really state of the art. And to show you where the sort of the field is changing. So this is where I'm from in Utah, beautiful place. But, you know, microsurgery is a very mature technique and continues to improve at a slower pace, but endovascular tools are evolving very rapidly. And stroke has become a major focus for a lot of endovascular work in America. And there's evidence in Class 1 guidelines that it works. And you can have a case like this.
Can you smile for me? Can you move your right arm?
So aphasic.
Can you move your right leg? Can you move your left leg? How about your left arm? Right leg.
And plegic on that side. And they do an endovascular retrieval. And this is what he is post-op.
Buzz got away. Buzz got away.
So it's amazing the results that can be done. And this is just from one of the companies that makes endovascular stroke retrieval equipment. And this is they feel their market over time. And look at this. So it's a very rapidly growing technique that's used in America right now with 20 to 25% growth per year. It's amazing. And we live in a very, in an area, we serve a very large area of the country. And we work with Viz.ai, an Israeli company that actually short circuits the images to us. And we completely bypass the system and bring the patient directly in from the outside hospitals through the scan to avoid the emergency room, to avoid unnecessary consultation, to save time to bring the patient in a rapid manner. So it works very well in our large rural area around us. So transfers occur quickly, they occur by air, and the patients get treatment right away. So let's talk about aneurysms, because I think that stroke is occupying a lot of time for the endovascular surgeon these days. And the volumes of stroke are much more than the volumes of subarachnoid hemorrhage and aneurysms. But aneurysms are an important aspect of what they do and an important technical aspect of what they like to do. And so I'd like to talk about the evolution of some of the endovascular techniques and where we feel surgery is still indicated. So coiling, as you know, has been out for 2 or 3 decades now. Here's a anterior communicating artery aneurysm. And this was attempted to be coiled in a rural hospital several hours from us. And they spent hours trying to get this. And you can see they lost the coil up in the artery here. And I think in some ways, there's so much prevalence of people coiling that we forget about simple surgical technique. The patient was stent down, and you can see all the embolic infarcts from the procedure here. And it's a simple matter to just go ahead and do a microsurgical removal of that coil and then clip the aneurysm properly. So I think that neurosurgeons need to be more front and center for being able to treat this disease. And the problem that we're having in America is a lot of the endovascular technique is not done by the neurosurgeons, but I think we need to be more involved as a specialty to manage this disease, because we see the entire spectrum. Here's another case. This was coiled in a hospital some years ago, giant cavernous aneurysm, and you can see the result, but you know this aneurysm is going to recur, and 6 months later, progressive sixth nerve palsy. And then we went ahead and did a bypass on this patient, a high flow bypass. So I think neurosurgeons need to be more involved, and they need to be front and center. And we encourage all of our residents that now they do endovascular training, they do stroke training, and we're having a large number of neurosurgeons in America being trained in endovascular. It's interesting, I have a fellow right now from Cambridge, and he's learning endovascular as well, because I think in Britain, the neurosurgeons haven't taken up the challenge of endovascular treatment as much as they have in other countries. So stents for brain aneurysms, 25 years old now. stent-assisted coiling. And but we realize that the mechanism of flow diversion is a little bit different than used in stent-assisted coiling, in that if you make the interstices of the stent smaller, you can actually direct flow away from the aneurysm. It's two mechanisms. It's flow diversion and re-endothelialization. And it's interesting because this requires dual antiplatelet therapy in most cases, but I'm going to tell you about a new device. But if you look at the data, it's very interesting. And in contrast to any other treatment we have for aneurysms, the flow diversion actually improves control of the aneurysm with time. So even surgery, we have a failure rate. But in all these studies, the flow diversion and the control of the aneurysm improves over time, which is remarkable when you think about it. And it doesn't need to be put in the main artery even for, so you can have these pica aneurysms, and our group published this where they just put a flow diverter in the vertebral and the pica aneurysm goes away. So a very important technique, and I think a real game changer, you know. So here's a pica aneurysm, flow diversion in the vertebral alone, and it controls the aneurysm. For these giant cavernous aneurysms, it's really revolutionized the treatment in my mind. We used to spend a lot of time thinking about doing bypasses for these patients, and I spent time in the lab, and we worked on techniques to help improve the operation to do a Petrus bypass on these patients. But here's a flow diversion. There's a partially thrombosed giant aneurysm. You can see the carotid is narrowed, and the flow diverter is placed here. You can see on this image. And this is what it does over time. It completely remodels the artery and the aneurysm is excluded. A remarkable result, considering the patient goes home the next day after surgery. And here's the long-term scan on the patient 6 months later. So it's hard to compete with that with open microsurgery, considering the bypasses that we used to do. And we spent a lot of time mastering these high flow. This is a saphenous Petrus to internal carotid artery bypass, Fukushima bypass. And now it's largely been completely superseded by the pipeline stent. And we spent a lot of time optimizing the surgical technique, increasing the exposure of the Petrus carotid to do this. Now, what about this issue of ruptured aneurysms? I want to show this case to you. So here's a 55-year-old woman with dense hemiparesis, a right P1 aneurysm. What would you do with this? Very difficult case. Look at the perforators coming off P1 right there. So I looked at this and I said, I don't know. I mean, we could bypass it, we could exclude it, but we're going to compromise the perforators from the P1. But this was the first case that we did a shield flow diverter on, which enables you to only use aspirin. You don't have to use Plavix or dual antiplatelets, just aspirin. And so we use pipeline flex, and here's the flow diverter. And over time, it took care of the aneurysm and there was no recurrence of subarachnoid hemorrhage. So I think the field is evolving quickly, and this has really been a boon and improvement in patient care. Look at the perforators are still maintained in this case. This web technology is another one for giant basilar aneurysms. And they size the device to the size of the aneurysm. It's good for these wider neck basilar aneurysms, which have a high recurrence rate, as you know. They're the easiest ones to coil, but they have the highest recurrence rate. So, and they're difficult and challenging cases surgically, especially the posterior pointing ones, as you know. So here's a web device, and this is the end result. There's other type of devices that are being developed all the time. This is the pulse rider. And the idea is that it makes a scaffolding and a partial stent over the wide neck of the aneurysm, and then they coil behind it. And this is all in evolution right now. So what are the problems with flow diversion? Well, here's a case in point. Here's a dorsal variant internal carotid aneurysm that bled in a young man. A flow diverter was placed, and he had a re-rupture a week later. So we still haven't really solved the problem of flow diversion in the subarachnoid hemorrhage patient. They are putting 2 flow diverter stents in these people now where they shingle them. They place one inside the other to try and get more flow diversion and less risk of repeat hemorrhage. This was the first case, this was my case, and this is the first case of a 5 centimeter long stent, flow diverter stent placed in this mid-basilar aneurysm. So a good friend of mine, Kim Nelson, put this in New York, and you can see that they placed the stent and the initial results look good, but I want to just point out that there's still a little bit of flow here in the proximal aspect of the stent. And then 24 hours post-treatment, you can see there's still a little outpouching and flow there, but the patient's doing well. She's doing fine, post-op CT1, day 6, she's doing fine, much better. And then she has a massive subarachnoid hemorrhage 2 weeks later and dies. So this is a difficult, now these mid-basilar fusiform aneurysms are difficult to treat by any means, as you know, but this is just a cautionary tale that we're still learning. So good judgment depends mostly on experience, and experience usually comes from poor judgment. So this is a problem, and we're still learning. And where do we still need microsurgery? Well, here's an interesting case. This is a salvage case where we used microsurgery for flow diversion. Here's a woman who had a large internal carotid aneurysm that was stented, and the stent came out from the distal end. And so what we did is we had to pull the stent out and then trap the aneurysm and bypass around it. So here's the stent, and you can see what's happening here is the flow is coming through the stent into the middle of the aneurysm. It's like a garden hose with pressure into the middle of the aneurysm. So we quickly took her to surgery, and we went ahead and pulled the stent out and then did a high flow bypass around this aneurysm. So she had the stent placed and it pulled out distally, probably not long enough in this case. This is part of the learning curve that our endovascular people go through. So we went ahead and did a high flow saphenous vein bypass into M2 from the carotid. And then we'll go ahead and trap the aneurysm and then pull the stent out of the aneurysm in the carotid. So it's remarkable.
1 minute left.
How long?
1 minute, sorry to interrupt.
Okay, sorry, okay, sure. So we'll pull the stent, and it's amazing because when you pull the stent, it narrows the stent and it makes it easy to pull. So very effective. So here's the post-op scan, and we bypassed and we left the ophthalmic open with the native. So in some cases, you know, we just need to operate because the aneurysm is a mass, and this is a giant aneurysm with a posterior circulation. Here's an aneurysm that had a distal vessel coming out of it. Here's an unruptured aneurysm. What would you do with this? Is there any endovascular treatment for this? This is right at the trifurcation of the middle cerebral. So we had to bypass distally into one of those branches and then go ahead and clip the aneurysm. So some solutions we don't have endovascular treatment for. Fusiform aneurysms, giant aneurysms, and I would tell you that I think that in some cases, we just don't have great solutions. Here's a case I did about a month ago. What would you do with this? This is a 51-year-old woman with a 3.5 centimeter aneurysm. She's becoming ataxic. She's got hydrocephalus. We shunted her and she progressed. So I took a look at this, and we had to do this under circulatory arrest. I haven't done that for over 10 years because I couldn't get the aneurysm. It was so buoyant, even with temporary clipping, adenosine. We tried rapid ventricular pacing, and nothing could get the aneurysm to to soften up enough to get the first clip on. So we did this under circulatory arrest. So these are dangerous cases, and we don't have good solutions. And so finally, I just want to say that we do need to maintain our bypass techniques for vascular surgery, for skull-based surgery, and we don't have good solutions, and endovascular is not going to be a solution in the long run. So we need to have a cadre of people that are trained to do these surgeries, and we need to pass the skills along in bypass and in difficult clipping techniques. And I'll leave it at that. Thank you very much.
Thank you very much, Professor Caldwell. Excellent lecture. Thank you. Thank you. I think we should have some minutes for discussion. I think we have time. Oh, Imad, Vladimir?
Yeah, do you mind to check if Dr. Mokos joined or not? Because I sent him a message.
Yes, sure. I don't see Professor Morkos connected.
No, I don't either.
It's not in the list.
Yeah, okay, most probably he got stuck. All right, yeah, I think you opened the venue for some question, comment, perhaps not only for the Dr. Caldwell presentation, but for the session of discussion, for all talks.
Yeah, both sections were really interesting. Maybe we could start with questions from the first session. I don't see any in the chat. Looking for it, but maybe one of the panelists would like to comment. All lectures were really interesting. Vladimir, may I just ask, I found in your last definition of consciousness really, really interesting. Is that yours?
In a way. When I started with the medical definition, I always thought that the consciousness is a better response of an organism than the reflex one. And from there on, you go higher up and you again end up in the Glasgow coma scale. So it means that I was always moving along the vertical line, not the horizontal. I get lost there.
Yeah, what was found very interesting was this story about awareness of the internal and external existence. And I was thinking about this when I was learned neurological semiology. My professor used to tell me that you need somehow the cortex to be, great part of the cortex to be in good health. And when you talked about the circuits and the death of localizationism, you know, when you think about a given task, you cannot think about a cortical area alone anymore. You must think about circuits. And you can imagine that you need several associated
question from the podium
to consciousness to exist. And also about the midbrain and midline and reticulata. There is no consciousness if you don't have mesencephalon, right?
I'm not sure about the mesencephalon, but the thalamus is absolute must, I guess. You know, and you are right in that it's not really the cortex, the neurons. It is the connections which are important. It is the connectivity between the arcuate fasciculus and the corpus callosum probably are the most important one structures. And that's probably the best is the image I have shown about learning the music. If you hear it for the first time, you switch on a large part of the brain. And when you hear it again and you learn it in a way, you switch on only small part of the brain. But you have no means to diagnose what other parts are involved. You know, the functional MR, which is on which most of these theories are now based, is insufficient in this, I guess.
Yeah.
So and awareness, well, awareness of something.
Yeah, and functional MRI is showing only gray matter, right? Functional MRI is not showing white matter. Yeah.
Dr. Igor and Vladimir, I just got a message from Dr. Marcos. He's connecting in 2 minutes because he was expecting, I think Anil Nanda's case was canceled, so that's why he was not good with the timing. In 2 minutes, he's connecting. So if somebody wants to talk to Dr. Franco Cervede and a specific statement, or he himself would like to say something.
Please, Professor Cervede.
No, I just wanted to thank everyone and my full gratitude to all of you for this fantastic meeting and for the pictures also that we showed of the pre-pandemic era. And the pandemic will finish and we will be back together. So I thank you all. I have to go because in 10 minutes I have the lesson to the students. But tomorrow I will be with you again, Imad and Vladimir. Thank you all for taking care of my presidency, helping me to work with you, all of you, and having fantastic meetings with the Neuroanatomy Committee. All the best.
Thank you.
Hi, Franco. How are you?
Hi, everyone. Thank you so much. Thank you for coming.
Stay on the web. We have Dr. Marcos joining us shortly. And please exchange some socialization among yourself. You have the chance now, 2 minutes. Najia, good to see you. And,
it's nice to see you too, and happy to join you at least in the end. And congratulations to this webinar, dedicated especially to our friend Franco for his great job during these 4 years.
Thank you.
And I'm sure that you will continue, of course, with us for a long time.
Thank you, Nadia.
Thank you, Franco. Thank you.
Hi, Dr. Kasadi, Dr. Aipe, and Dr. Dong Van Hee. They joined us. Aipe, you want to say something?
Well, Franco has been a very good friend. I remember the time that he was elected in Rome. I remember the ride back with him to Parma. I hope you remember Franco. And
yes, correct. I remember very well. Thank you, Ipe.
More than anything, I would say he's a very good human being and he's been an excellent leader. So thank you, Franco. Thank you very much.
Franco, you have applied your hospital name Humanitas, and you are really a messenger of the humanity. Thank you very much. Please go ahead for your meeting, and we don't want to hold you longer.
Okay, thank you so much. See you tomorrow. See you all tomorrow. Vladimir, thank you again.
Ciao, Franco. Ciao.
Ciao, everyone. See you tomorrow.
There is one question in this chat for Professor Quadwell. Maybe we could.
Sure. Yes. Yeah. I answered it through the chat, but basically we look at each case. I think it's an important question. So the question is, how do we choose whether to use endovascular or open treatment? And what we do is we have a multidisciplinary committee where we have endovascular and open surgeons, and we discuss the risks and the durability of both treatments. And I think it's changing because, as you know, every new advancement is a little bit of an advancement on the endovascular side. And so the discussion changes with the new technology. But we try to make a decision as a group, which is the safest way to take care of it, and then also durable. Because we don't like to do treatments, especially when we treat these patients coming from a distance away in this rural area. We don't like to have them it's very expensive for them to come back and have follow-up treatments and angiograms and such. So we try to use treatments that are durable and don't require a lot of close follow-up. And then, as you can see, sometimes we get complications from both sides, and the endovascular can do a salvage for open surgery, and open surgery can be a salvage for endovascular. So I think it's an evolving interface, and it's fascinating to me. I can't believe in my career the advancements that the endovascular people have made. It's really, and they've really improved treatment with so many of these diseases, like giant cavernous aneurysms is an example. That's a dramatic one, where I think I did a high flow bypass for one of those in India recently. But we haven't done one in America for probably 7 years because the pipeline is so effective. So thank you very much, Igor.
Okay, thank you. Thank you again.
Bill, can I ask you something?
Yeah.
Where from endovascular people in the US are recruited? Because in our country, all of them or almost all of them are radiologists originally. It means that they do not have the clinical education. Thus, it's always the joint decision between the clinician. It means a neurosurgeon and an endovascular guy who is a radiologist, not a clinician.
No, most of the 3 of our 4 endovascular people here, Vladimir, are neurosurgeons. They're my partners. And this is the way that we need to go, I think, in the future. And I've talked to many of my friends around the world about this, because then the neurosurgeon has the equipoise to decide what they think is the best treatment, and they can see the risks and the benefits of both treatments. And so we now are training all of our residents. It's part of our board requirements. They have to do endovascular treatment and they have to do some stroke intervention. And then we're training them so that if they do their residency, they can do 1 more additional year and be certified as a interventionalist. And so we're making it easier and easier for the neurosurgeons to do this. Remember that if you go to a rural area, if it's a radiologist doing the intervention, you still need a neurosurgeon to back them up and that type of thing. But if you train neurosurgeons to do it, they can back themselves up. So it's a very much more efficient model if you train a neurosurgeon to do this work. So we're really pushing towards it in this country.
Yeah, I think it's a very exciting discussion, but maybe we should discuss it after.
Just before you ask your question, Jack is with us.
I was telling, is a very interesting discussion, but we can maybe continue the discussion session after Professor Morco's lecture. So Professor Morcos, welcome. Thanks for joining us.
Ahead of time, so no worry.
Yeah, sure, we can discuss later. So Professor Morcos will present us his lecture on bypass surgery for moya and ischemia.
Hi, everybody. Sorry, I did not realize you're so ahead of time. So I would have joined earlier. I'm sorry, Bill, I missed your talk. But
no
I'm
problem.
Sure you and I will meet again soon somewhere else. So this is, we're honoring Franco Serva Day today. I am delighted to be part of this. So I thought I'll talk to you about direct bypass surgery, some my experience with 162 cases and some recent thoughts I've had about this. But let me start by saying what a pleasure it has been working with Franco, him as WFNS president and me as chair of this Constitution and Bylaws Committee. Remarkable individual who is focused, who knows what he wants, who says what he means and means what he says. So I'm not going to waste your time singing his praises, but I thought I'll have fun by doing anagrams of his name. You know, an anagram when you rearrange the letters of a name. So there it is. You can rearrange his name. You get things like increased favor. So certainly he did me a favor by being the president and working with me and me working with him. And also a sardonic fever. He is so tense and so, very passionate about what he wants. And you can come up with other anagrams that would summarize a little bit his character, but those two fit the bill quite a bit. My disclosures are irrelevant. I'd like to thank all of these contributors, particularly the first author there, my last year's fellow, Nick Kahn, who really helped study my data, and a bunch of our residents here at the University of Miami, and of course the string of stroke neurologists with whom I have managed almost all of these patients. What is the background? Adult moya disease, what is the natural history? If you don't treat them, 50% of them will progress over 6 years. Annual risk of stroke, 13%. Hemorrhage, 1.7%. It's worse if it's bilateral. The annual risk, if asymptomatic, is 3%. Adult Moya disease, direct bypass versus indirect, there is a lot written about it. The meta-analysis shows that there is a higher degree of revascularization with direct STA-MCA bypass compared to indirect. The direct is more effective in reducing recurrent ischemic strokes. Steno-occlusive disease, meaning atherosclerotic disease or non-Moya-Moya disease and non-Moya-Moya syndrome, there is still a role for direct bypass surgery in spite of what the COS study said several years ago. Even recent papers suggest that it does lower incidence of ischemic stroke and cerebrovascular death in properly selected patients. And direct is better than indirect in that group. The role of direct versus combined direct and indirect bypass surgery, I wanted to examine this, which is why I looked at my series retrospectively in Moya-Moya disease, Moya-Moya syndrome, and steno-occlusive disease. It's retrospective. I'm the single surgeon in that series. I looked at everything you can think of, the outcomes. I'll show you the data a little later. Particularly intraoperative blood flow measurements, which I do routinely, as does my good friend Fadi Sherbel in Chicago. And this is following his lead, using his flow probe that he developed back in the late 90s. I then compared 3 techniques, what I call 1D, 1R, meaning 1 donor, 1 recipient, or double barrel, which is 2 donor, 2 recipient, or 1 donor, 2 recipient. And I'll discuss those briefly later. Obviously, I'm very selective in general for which cases go to surgery. I always obtain physiological testing, such as preoperative vasomotor reactivity studies, CT perfusion, MR perfusion. In the past, I used to do SPECT diamox, breath holding index. I really never do, unless it's an emergency, I never do a bypass in this day and age when people could criticize you for doing a so-called surgery that has no indications and does not work. You really need to to have solid grounds to do it. And I do that by obtaining those studies. Particularly, it's not so controversial with Moya-Moya, but particularly with SOD, steno-occlusive disease patients. I reviewed in retrospectively the angiograms when we were able to find them, the pre-op, we graded Matsushima grading, all the radiological reviews. This is a typical case, for example. You can see the final follow-up at 11 years in the bottom, a very mature bypass. You can see what we started with, a very bad Moya-Moya disease. This is the middle row is 3 months post bypass, and the bottom is 11 years. That's how we want all our patients to look. I remind you of transcranial Doppler vasomotor reactivity study. It's a well-known technique. Our neurologists use it very well here. They have excellent technicians to do it. The normal range should be more than 70%, and then you can see the numbers when it is impaired. In COVID times, it's easier to do breath holding index rather than a VMR, and a normal breath holding index is also more than 0.7. Statistical analysis. So here are the results. Let me just minimize this a little. Okay. So the results, I have done 162 procedures. It was bilateral in 72, mean clinical follow-up, almost 3 years, mean angiographic follow-up, 1.75 years. And you can see from the graph that in spite of the COS results, actually my referral numbers have gone up. These are every 7-year period. And the last 7 years, I've done more than 100 bypasses. Of course, I was doing a lot less early in my practice. So to show you if you maintain an interest and you have stroke neurologists who don't follow blindly what a randomized trial says and treats every patient as an individual, and every patient is different. You can, there are indications still. What are my results? Post-operative morbidity, 3.7% stroke or intracranial hemorrhage, death in one patient, and really that death was, to be honest, an anesthetic death during I was doing a bonnet bypass, and the patient woke up during the suturing to the Sylvian fissure and developed massive posterior fossa hypertensive hemorrhage and died 3 days later. Long-term stroke or intracranial hemorrhage, 2.5% post-op. Bypass patency was 100% in the immediate results, immediate post-op period. At long-term, 10% gradually occluded, as has been seen in many other series, 90% long-term patency. Transcranial Doppler VMR improved in general, but never returned to normal. You cannot expect the TCD VMR to return to normal, even in patients who have no more symptoms and have a perfectly patent bypass. And the intra-op flow measurements, the cut flow of the STA on average was 52 cc per minute. The bypass flow, when I finished, was 44 cc per minute. The cut flow index, which is a ratio of both, was quite good, 0.86. The modified Rankin score improved post-op. Here is a busy slide showing 3 columns: Moya-Moya disease, Moya-Moya syndrome, and steno-occlusive disease. I don't expect you to look at the demographics. This is just to show you that we really analyzed every comorbidity in each one of those 3 groups. So then we did univariate and multivariate regression to see what correlates with bypass occlusion, even though, I repeat, angiographic bypass occlusion is not a big deal at all, because as you will see, usually it's due to collateral formation from indirect collateralization. But in any case, there were only 2 factors that correlated with direct bypass occlusion. One of them I really cannot explain. Hispanic race, I mean, most of my patients here in Miami a lot of them are Hispanic, of course. I don't know why that correlates. I don't know if this is just one of those statistical flukes. I'll be interested to see other series. I have not seen it in other series. But the most important thing is whether there was complete or incomplete angiographic collateralization pre-op. That clearly predicted. Now you might say, why am I bypassing patients who have complete collateralization? Because this is a qualitative image. These patients were still symptomatic. They still had very poor VMR and TCDs, but this was, in retrospect, what was found. So here is a very dramatic demonstration of when you overlap all the angiographic injections, the effect of complete versus incomplete preoperative collateralization. 4% only occluded their bypasses if it was incomplete, and 36% occluded if they were complete. And you can see the complete are in blue. So there weren't too many of them, but it was quite striking and not unexpected. But this shows you that patients improved. Pre-op modified Rankin score compared to post-op. This is a comparison when I did 1D1R, 1D2R, or 2D2R. It was a trend without statistical significance, a trend for increased blood flow, of course, the more anastomoses you put in. I then, because my results really did not show that the cut flow index correlated with bypass occlusion. This was a very strong finding in Fadi Charbel series at UIC in Chicago. So I could not understand why kind of two similar series ended up with two separate results. They published there in 2019, they had 146 cases. Mine is 161. The flow ranges are all very similar between both series, but here is the difference, I believe, that explains why their patency rate, I'll go to the next slide, the UIC patency rate long-term is 76%. Mine is 91%. It has nothing to do with technical things at all, because this is long-term, this is not acute. And I believe the explanation is because Fadi and Sepi Amin Hanjani use concomitant EDAS in 35% of their cases. And I don't. I only do direct STA, MCA bypass, 1 or 2 anastomoses. And I think that probably explains why, when you look at the cut flow index stratification, in my series, it didn't matter what the cut flow index was. The occlusion rate was about 11%. In Fadi's series, if the cut flow index, that first row where the red arrow is, if it was less than 50% or 0.5, more than 54% of his bypasses occluded in long term. It's very interesting finding to really compare the two series. I published my 1D 2R technique in May of this year as a video. And if you want to actually go into the detail of the subgroup of doing one donor, two recipient, using only the parietal branch of the STA, so you don't waste your time dissecting the frontal branch and make the craniotomy small and quicker and all that, that is published in August. And a lot more details, particularly calculating the flow, the vascular resistances. And if you're interested in that topic, look up the paper. Those are the 3 steps of how you do 1D 2R.
You have 1 more minute, Professor Morkers.
Perfect, thank you. I'm gonna skip the video. This is how it looks at the end. 1D 2R, you have 2 anastomoses side to side and end to side with 1 donor branch. This is what the flow looks like. 57 when you start, 36 when you finish the first anastomosis, goes up to 52. This is average, these are average numbers. 52 when you do the second anastomosis. It is very much like Ohm's law. Poiseuille's law is like Ohm's law. The new concept that we introduce in that paper is SARA and SASI. It has to do with calculations, with cut flow index and flow measurements. Again, I don't have time to go into the meaning and the details of this. My conclusion is that direct bypass is beneficial in appropriately selected Moya-Moya disease, Moya-Moya syndrome, and SOD patients. I've achieved long-term patency 90% of 162 cases. I never failed I only failed once to construct a direct bypass in one of 162 patients. In that case, I did an indirect. MNM, morbidity mortality, is very good, much better than the cost. It was 3.7%. Long-term event rate is low, 2.5% over almost 3 years. Modified Rankin score gets better. When bypasses occlude in a delayed manner, they do that asymptomatically, except in one of my patients. Intra-op blood flow measurement is extremely useful in making you design your bypasses and understand what you are really doing. 1D2R is now my favorite technique to use. There are some exceptions, but I'll save it for the discussion if you'd like to ask me questions. Thank you very much.
Thank you, Professor Morkers. I think we can start the discussion. Professor Morkers, you have one question in the chat from Dr. Parek. Could you please comment on the revascularization procedure in comparison to
Oh, he's asking about
yeah, I think what he means is indirect versus direct revascularization for pediatric patients.
Oh, no, none of what, yes, none of what I have said applies to pediatric. As you all know, the data in pediatrics, unless it's an absolute emergency, indirect bypasses in children work as well as direct. But it is in adults that I have made the point, and I'm making the point again today, not just based, I cannot convince you with my data because I don't have a comparison with indirect. You have to see the literature that I quoted you to show that indirect, by and large, through meta-analysis in adults is better. Assuming, of course, your experience at doing, direct is better, assuming you are experienced in doing direct bypasses.
Yeah, sure, that's the tendency, but how would you put a threshold, you know, pediatric, adolescent, adults, Moya disease, Moya syndrome, sickle cell disease, this also so confusing. Sometimes not that easy to see, okay, this is for an adult way of reasoning and approaching, or this is for indirect, like in typical pediatric cases.
Well, I mean,
right?
I mean, my take is that, I mean, you know, I don't do pediatric neurosurgery, but if they come my way, I do direct because, you know, I'm experienced with it and I know it gives immediate flow. But I would say, you know, below age 15, you probably can get away with indirect bypasses. From what I see from my colleague pediatric surgeons, the excellent series of Scott in Boston over the years, very hard to argue with those results.
Yeah, thank you. There is a second question. I think it's a more general one about hybrid neurosurgeons. Vascular and interventional, I think it's for all panelists, but if you want to comment, Professor Marcos, yes. Professor
it's not the future, it is the present. I mean, at least in the US, I mean, the people like me are dinosaurs. There are, I mean, most cerebrovascular surgeons in the US today are hybrid neurosurgeons. Again, I mean, to us in the US, this is the present and the future. And I know it's not the same in other continents or countries, but it is for us. But I encourage other panelists from other countries and continents to comment.
Professor Codell,
yeah, I mean, I think we already discussed this a little bit, Jacques, just as you were loading your slides, but I was saying that, you know, as at the board level, we're trying to train the neurosurgery residents in endovascular techniques during residency, and so they can shorten their time postgraduate in doing a fellowship. And you know, it's a very efficient way of providing care in my mind, because the neurosurgeon is necessary to provide stroke care. But if the neurosurgeon does endovascular treatment as well, that's a one-person stroke program. Whereas if a radiologist does it or a neurologist does it, they need a neurosurgeon as well. So, I mean, it's an efficient way to provide care to rural areas like ours. And we're very much advocates of it. And I really enjoy seeing the neurosurgeons get involved with it, because I think we're blessed in neurosurgery. We've got such talented and hardworking people, and they're really the center of gravity for endovascular treatment now in America. I agree with you completely. They've really assumed the challenge, and they've enjoyed it. And so I encourage other countries to look at it as a model. I think it's a great model.
By the way, I can't remember who wrote the paper, but they did a comparison of endovascular outcomes between hybrid neurosurgeons, interventional neurologists, and interventional neuroradiologists. To be honest, I can't remember if it was only a US data or it was more than that, but you'll be pleased to know the outcomes from hybrid neurosurgeons were the best ones among the three groups.
Which makes sense when you think that training in endovascular neurosurgery is not only intervention itself is a lot about the clinical training, which is also an important point. And we have clinical training. Actually, I think it's a situation that is still evolving. I see that interventional neurourology or interventional neurosurgery has changed a lot in the last years. The profile of the specialty is changing. We're discussing some minutes ago about stroke. So people that were thinking about interventional neurology 15 years ago were thinking about aneurysms and AVMs. So we are not treating EVMs as much as we used to treat in the past. And at treating aneurysm, there was a lot of programmed interventions, and now we're doing a lot of stroke. It's mostly urgent interventions in the middle of the night. So there's a real change in the profile of the specialty. So the next generation will look different to this subspecialty, I think. So this situation is still evolving. I don't think it's already really stable. So what I mean is that people who's doing interventional neurology and the hybrid neurosurgeons, they are changing. Their profile is changing. I work in a country, and most of those people are radiologists, but I'm seeing more and more neurologists and neurosurgeons coming to the angio suite. So it's a real evolution is not finished yet. Any more comments, Vladimir?
Yeah, neither of us discussing here is a hybrid neurosurgeon. I'm just a little afraid of being biased when you are the one, when you have both techniques at your hand. There used to be a guy in Austria a few years ago, and he was the only hybrid in Europe at the time. And he had phases when he was having no complications with surgeries, then he was in favor of surgery. Then he had some complications in the surgical procedures, so he switched to endovascular, and he was advocating endovascular. And it was like a sinusoid. And I always was thinking that it's better that when two people are doing it at one place, if they are together. This is in my institution that the guy who is doing interventions, and he's a neuroradiologist, is sitting with us on all the morning conferences. There is not a single aneurysm which escapes our attention. And ultimately, we as neurosurgeons are those who decide. So I'm really not sure about the hybrid concept.
I would like to comment on this, Vladimir. I'm very sure about this concept in education. I think it's really important for neurosurgeons.
It's a different matter.
During training, be exposed, so because the clinical discussion afterwards will be completely different. Ramesh?
I just wanted to mention, like in other specialty, cardiology, it's taken over by the cardiologist doing intervention. And if you lose this, we might lose the whole aneurysms, and especially at the moment, we keep hold of the patient and then just treat their complication from all the subarachnoid and all the complications from the intervention. But ideally, we should also be involved in it. I agree with that, but also there will be a bit of bias if you tend to do both. I don't know whether one is possible to excel in both specialties if you do it by yourself, probably rather than to try and focus on one thing. But at the same time, it's important that we should have our own colleagues and neurosurgeons dealing with the endovascular technique rather than giving it to the radiologist or other neurologist.
I think that's a good comment, Ramesh.
Yeah,
I will tell you the experience that I've seen is that I've trained a lot of young people that have gone on and done endovascular as an interest. And if they do endovascular, they tend to migrate towards more endovascular because they feel more comfortable with it.
Exactly.
I think the learning curve is such that it's a little easier to learn the endovascular and to be a master at it earlier than it takes to do 10 or 20 years of microsurgery, as you know. And so that's the trend I see. However, I do think it's important for us to be involved for the reasons that you mentioned, because we could be excluded, you know. I mean, the neurologist can take care of the stroke and the radiologist and the neurologist can do endovascular. and then they call us when they need a decompression or the clot removed. And I think that it's a big part of business, and it's a big part of what neurosurgery is. And I just like to remind everybody that neurosurgeons were the first neuroradiologists. You know, in the 70s,
that's right.
All the angiograms were done by radio or by neurosurgeons. In fact, Yazergill wrote a textbook on angiography in the 80s. You know, so this is history is just repeating itself here. But I think neurosurgeons should not be excluded from the business. Is my point. You know?
No, but I fully agree with Vladimir that what I saw in my own department, that the people becoming very good in endovascular, the neurosurgeons, they became very careful or maybe even anxious vascular surgeons, because they started to with the clipping, and then they said, no, probably can't. I still can try to coil it. And that's they became reluctant to do that. And that's a difference from a neurosurgeon, like many of us were trained, when clipping was the only possibility. You went all the way. You never considered any other possibility. And that's the way. I have seen several cases, and I mean, still, I believe that it is good that neurosurgeons do endovascular work. But I agree with Vladimir that doing both, you can't do it on the same level. That's a difficulty. They can be excellent endovascular neurosurgeons, but they become less good open.
Yeah, they're less comfortable. They're less comfortable.
Yeah, Andre, it's
Therefore,
very
it's
easy.
good to have them both. Them both.
Yeah,
in your
Andre,
department.
it's very easy. You cannot be a world champion in table tennis and skiing.
Yes.
It's either or.
It's very, very good. No, it's probably only one, but I saw that. That was just that they often called me in and said, well, this is an unclippable aneurysm. We will close and we do it endovascular. We had a hybrid OR, so you can do both procedures on the same time. But then I said, let me have a look. And the end was often that within an hour, it was just clipped. So it's a difference, because I'm not doing endovascular, but it's a different approach to the problem. And it's good to have them both in your department. And it can be a radiologist or a neurologist or a neurosurgeon very well, but in both of it, very hard. That's all I wanted to say.
Yeah. How is it in the US? Those people doing neurosurgeons doing endovascular, are they doing majority or exclusively, or are there two people, one doing clipping, the other, but they are in the same department?
Yes, well,
this is our practice, but how is it in the US?
They still do the clipping. They also can clip it, but they are sometimes too much reluctant to go for it in the clipping part, because they have the tendency to go more to think endovascularly. That's maybe the mind is more towards endovascular, even when they are doing open surgery. Because the one who started in my country was my colleague, who already was 16 years open vascular neurosurgeon and then became endovascular neurosurgeon. And he can do it both, but now his open surgeries simply decline.
So the way it works in our department from a practical standpoint, Vladimir, is that the endovascular neurosurgeons clip the simple aneurysms, and then the difficult ones and the bypasses, I usually help them with.
Exactly.
That's how it is from a practical standpoint. Because I completely agree with you. You can't be a world-class open surgeon and a world-class endovascular. There's just not enough time in your life. Yeah.
Yeah, I think Professor Kenna makes a comment on that.
Well, you see, there is no wrong or right. And I think most of the senior of us, we feel they have to be two separate services. But I can see the point if you train somebody early in their practice. Most of these people you are talking about, they didn't adopt that approach when they first joined the residency training program. When they are grown up, you still have people, they can be very good tennis player and a piano player. I mean, it doesn't mean that this is contradict this one. I still believe they have the material. Patient material is important. Exposure is material. exposure is important, and have expertise in the two fields. If you have expertise in one field and not in the other field, they will deviate and they will be having difficulty making decisions. If you train them by two experts that they are expert in the field, I'm sure there will be a new generation different than us, because we like to be surgeon, and this is the clinical decision. I still believe what Ramesh said is a clinical decision. You cannot leave it completely the radiology. This should be important that the neurosurgeon make that decision, select the patient. Sometimes if you leave it to the intervention radiology, their decision selection is different. They will leave you, you will end having trainees doing only the complex vascular surgery, not the straightforward surgery, because they are exposed to a ruptured coil and they have to go, and it's very difficult if you don't show them the whole picture.
Absolutely, Imad, because that's the advantage of having a neurosurgeon also doing endovascular, because he can think clinically, he can think surgically. It is not that the person can really execute it to the fine. But I fully agree, there's a difference in judgment, as Ramesh was saying, between a radiologist and a neurosurgeon doing endovascular techniques. Absolutely.
Okay, this is something very interesting. First thing first, there cannot be a hybrid. I mean, I always feel that there cannot be a hybrid neurosurgeon who is very good at both, but there should be a hybrid department. Yes. Rather than a hybrid neurosurgeon, it should be, because to be at the highest level, you cannot be a hybrid neurosurgeon. You have to have a colleague who's doing, endovascular. So only then you could be at the highest level. If you're doing both alone, as I saw all the opinions here, you could not be at the highest level. You could be doing both, but you will not be at the highest level, and that's not what you want.
That is what Dr. Caldwell was saying, Ipe. That is what he is doing.
Let me just comment on this. I completely agree with you. You cannot be at the highest level. That's not what you want. You want to be good. You want to have your domain of expertise, but you don't have to be expert in everything. But you need to be honest with yourself, honest with your patient, with your clinical practice. Yeah. But you must be able to think in a hybrid manner. You must be able to discuss with interventionalists.
You are a clinician.
Yes, absolutely.
By no way I would like to be called hybrid. I wouldn't like it. It is a very pejorative connotation.
Actually, Vladimir, many of them, many of the endovascular surgeons don't like it. They like to use the term duly trained, not hybrid.
That's a little better. That's a little better.
Agree. Nice discussion.
Yeah.
And interventional radiologists, I believe, should not be into coiling, because if you're not able to handle your complication, you should not be doing it. That's what I believe. So if you put in a coil, or if you put in something, and if the patient develops a stroke, or the patient's head needs,
so it brings us back, who should, if they are not privileged to put the coil because they cannot handle their complication? You said it. Who's going to put the coil?
Well, neurosurgeons should, but they should not be clipping. It's very simple. So
no, as Dr. Caldwell was saying, they are still trained neurosurgeons. Yeah. And I fully agree. I like that concept very much. They can do the easy ones, let's say the straightforward clippings, but they will simply not have the ongoing exposure to bypasses, to difficult aneurysm, posterior circulation. So let's say those cases, as Dr. Caldwell was showing, these are for the very, very versatile open vascular neurosurgeons. And actually, in my department, they simply don't want to do it anymore, because they realize themselves that they are not fit enough to do that openly, but they do it endovascular, but they still can think neurosurgically. They know how to open the skull, how expose to Sylvian fissure, how to go to an MCA. That still they know that, they are trained in that, but they will never reach that level, as Vladimir was saying. You can be a decent tennis player and a decent piano player, but you will not be a concert piano player, and you will not win Wimbledon or the Grand Slam. That's the point. That's the issue, not both.
Andre, can I be the devil's advocate? And probably what is not being said in this conversation is that probably, and you will have to ask, maybe Bill and I can ask our younger partners who do endovascular, they probably assume that the skills are not going to be needed. That the skills of Bill, myself, and others who are pure micro, our skills are going to be phased out, and industry and technology are going to be replacing the needs for those giant surgeries, and they are and the question is, it's a theoretical discussion that time will come where it's irrelevant that you don't need two people. You know what I'm saying? Just throwing
Jacques, I think that there will be a time that many things like skull-based surgical techniques and probably not even the ability to operate on the meningioma or glioma will be necessary anymore. I still remember that World Congress in Acapulco. That was in 1993, and there was one little session on coilings, and it was Professor Moret, and he was quite angry that only 3 neurosurgeons, I was one of them, was attending that session. And he said, how is it possible? Within 5 years, there will be no clipping at all in the whole world. Well, okay, we are now 30 years ahead, so there will be quite some time. And until then, we still need those techniques. And also that will develop. So I doubt that we, then probably also endovascular techniques will be replaced by nanotechnologies or anything else. Until then, we need both techniques.
Yeah,
Andre, I'm happy that people like you and Bill are still around.
Yeah, Andre, in 1971, during the EANS Congress in Prague, there was a special session on microneurosurgery, chaired by Yashargil. There were 10 people there, no one else.
And they say...
Yeah, there is one more point which I would like to highlight. I think Bill has spoken about it. In many places, neurosurgeons resigned to stroke. Stroke is, in my mind, integral part of neurosurgery. Those are carotids, STA, MCA bypasses, whatever you name it, thrombectomies. And in many places, the neurosurgeons really resigned this. They are not doing carotids, they are not doing thrombectomies, or not done in their departments. And this is something we definitely should keep within the specialty.
Yeah, it's a neurosurgical disease. It is a brain disease, a vascular brain disease. And that is what we should, and it is amenable to surgical solutions. Not all of them, but and of course, we should be involved as neurosurgeons. Fully agree.
The other important point I just want to mention that what we are talking about is not for the general neurosurgeon. We are talking about a vascular neurosurgeon. He is very specific what he is doing, and he should be aware of the two systems. I mean, whether it's interventional or surgical. Vascular surgeon is a very specific line of training. There's not a general neurosurgeon who's going to do clipping or putting the coil.
Well, Imad, many surgeons around the world are mainly doing spine and trauma. I mean, that's the reality. But now we are discussing these very special diseases, and not in all places it is possible to be treated, but it should be in specialized centers. And I hope still that we can train people. And it is good to see that just 20 years ago, we were discussing that vascular neurosurgery was dying off. It would not be a part of training because there would be no clipping anymore and only radiologists would take care of it. And it is good that we now see that neurosurgical trainees are again have interest in vascular neurosurgery because they can be dually trained, as Jacques was saying. And that's good. They can be trained in both. And they love to do that because it is also a technique. I mean, you need a dexterity to do that. And you have to understand the vasculature of the brain. And I think neurosurgeons are fit for that.
I think the challenge that I see, Andre, going forward is that we need to have a cadre, probably a small group of people that continue to do the microsurgical aspect, because there's some of these cases like that giant basilar that I showed you that are going to be required to be treated open, and we need to make sure that we maintain the talent of people to be able to do that. And in America right now, because there's such a prevalence of endovascular training and prevalence, and the people, as you said, migrate towards endovascular over time, the ones that do it, we need to make sure that we have an adequate training pipeline to be able to do that. And I think that's the challenge that I see we're facing. And there's a few fellowships, Jacques, myself, Mike Lawton, Mayo Clinic, that kind of thing that does it, but there's not a lot. And I don't know how we're going to do that.
No, but we probably don't need so many. We should try to figure out that maybe even in a country like the US with the 280 million people, you need 6 centers or 8 centers capable of doing that. And in my small country with 17 million people, probably we don't even have 1 center. It could be in Netherlands, Germany, Belgium. Let's say with 120 million, you have 2 or 3 centers. This will be a very concentrated kind of technique, because otherwise, if you do this only once a year, you simply never gain experience.
Yeah, and I think that skull-based surgery and vascular surgery, they're like collision tumors. The skill sets really cross over nicely. And so I think that's probably the model for these people that do it. The thing that's a challenge in America is the insurance companies often define where the patient could be treated.
Yeah, that's a problem.
And so we're not there yet. And so I don't know, maybe Jacques, do you have any better ideas?
No, I don't think so. I mean, you know, you said it
Well,
well.
Jack, he gave his idea earlier. I think he called them the playground of the 2 disciplines.
Yeah.
Vascular and skull base.
But Jacques, I saw that you have to leave. It was great
Sorry,
seeing you.
I have to, yes, I love this conversation, but I must leave you guys.
I know,
I'm sorry.
I know.
I'm making
Great
many
seeing
people
you.
angry.
Thank you for joining.
Thanks, guys.
Thanks.
Jack. So this is the thing.
Andre
Actually,
I heard
think,
that you, Andre Brotenius, I heard that you were in Acapulco in 1993. So we can continue this interesting discussion next year on May. We are going to organize a course in Acapulco on May and in November in Villahermosa, Tabasco. These are very beautiful places. Vladimir Benes has come to Southeast in Mexico several times. So all of you are invited.
Victor, I've been to
great,
Acapulco in 93 too, and I nearly drowned because I was stupid enough to go directly into the sea. And the current started to take me away to Hawaii or
back to Europe.
Yeah, back to Europe.
And thanks, Bill, for joining.
Thanks, everybody. Have a great day.
Seeing you.
Thank you.
Great, thank you.
Thank you. Bye-bye.
See you. Bye-bye. Tomorrow. Bye-bye.
So tomorrow is another day, and remember tomorrow, 12 o'clock GMT, will be 2 more sessions. Thank you for everybody.
Thank you.
Very good.
Good night.
Good seeing you. See you tomorrow.
See you tomorrow.
See you tomorrow.
Take care.